Good morning. Welcome to the Senate Committee on Commerce and Labor for the 81st legislative session. Before we begin, please make sure to mute your microphone when you're not speaking to minimize the background noise. Madam Secretary, call the roll.
Senator Hardy?
Here.
Senator Lang?
Here.
Senator Neal?
Here.
Senator Pickard?
Here.
Senator Scheibel?
Here.
Senator Settlemeyer?
Here.
Chair Spearman?
Here. Okay, let the record reflect that we are all here today, and I'd like to take care of a couple of housekeeping items before we begin. Today we will be hearing Senate Bill 190, 198, and 229. As you know, the legislative building is currently closed as a public safety measure to reduce the spread and infection rate of COVID-19 to the public, and so all committee meetings will be held virtually, meaning committee members, staff, and everyone else will participate either through Zoom, video conference, or by telephone. However, there are various ways of that the public can engage with us and participate throughout the process. These include registering to participate through Nellis, where you have the opportunity to testify on a bill or provide public comment during the meeting. You may submit written comment to the committee email address or fax number listed on the agenda. You may share your opinion via the legislature's opinion of application on Nellis or by viewing committee meetings online through Nellis on the legislature's YouTube channel. To register on Nellis, simply click the Participate button near the committee meeting date and time, then fill in the required information such as your name, the agenda item you're interested in, and your position on the bill. Once your registration is submitted, you will see a confirmation screen and will also receive an email with a phone number and meeting ID number to call in at the time of the meeting. Just a note that while meeting registration is required to participate, it does not guarantee you will be able to speak. Similar to previous sessions, comment and public comment may be limited due to time constraints. And I will announce the time frame, that is how many minutes for each response, for, against, and neutral. It will be helpful if more than one person in your organization wishes to comment to remember that ditto is a good response when someone has already covered your points. This will allow more people to comment during that time frame. When you're on the phone line, please pay attention to which bill is being considered and follow the verbal prompts provided by the BPS staff so that you know which keys to press to raise your hand or unmute yourself. Staff will call on you to speak by the last 3 digits of your phone number. Detailed instructions for participating in committee meetings are also available on the help page, which is linked in the banner at the top of every page on Nellis. If you need assistance with any of these processes, or if you would like to receive electronic notification of the committee's agenda and minutes, please contact our committee staff at the email listed on the agenda. Any exhibits for the committee must be submitted in electronic format no later than 8:00 a.m. the day before the meeting to our committee staff. Contact information may be found on the committee page in Nellis. In addition, any person proposing an amendment to a bill being heard by the committee must first talk to the sponsor and let them know that you intend to submit an amendment. I will not entertain any amendments if the bill sponsor is not aware of the amendment. The proposed amendment must be submitted in writing 24 hours prior to the meeting. Please include the bill number, a statement of intent, and your contact information. When testifying, please remember to unmute your microphone and clearly state your name and the entity you represent at the beginning of your testimony. Speak clearly and please project your voice to ensure that those watching remotely can hear your testimony. Remember to turn off your microphone when you are finished speaking. A reminder to all of those who testify pursuant to Nevada Revised Statute 218E.085, it is unlawful for a person to knowingly misrepresent facts when testifying before a legislative committee. A person who knowingly does so is guilty of a misdemeanor. The chair and any member of the committee may request a testifier to submit documentation supporting their testimony. Committee members, during these virtual hearings, when an agenda item is called for a vote, our committee will be using roll call to do so. When the committee secretary calls your name, please answer with a yes or no so that there is no confusion. Also, if
I
you
was going
have
to text him, see how he was doing.
your hand, hello? Please raise your hand through the Zoom application. Somebody doesn't have their mic muted. And finally, all exhibits received prior to the meeting will be available on Nellis Online. Broadcast, can you just ask everybody again to mute their microphones, or if you can do so, please do so.
Yes, Chair. Everybody, please mute your mics. And once the chair calls on you, or if needed to be called, you could feel free to unmute.
Thank you so much. I will now open the hearing on Senate Bill 190. Senate Bill 190 provides for the dispensing of self-administered hormonal contraceptives. Senator Cannizzaro, our majority leader, please proceed with your bill introduction.
Thank you, Madam Chairwoman and members of the committee. I appreciate being here with all of you in Commerce. My first appearance of this legislative session, which feels a little strange, as this is a committee that I'm pretty familiar with from the last two sessions. So thanks for having me this morning.
Welcome. We've got bells and wells ringing in the background to welcome you.
Well, thanks. So again, thank you, Madam Chair and members of the committee. For the record, my name is Nicole Cannizzaro. I currently serve as a senator from Senate District 6 in the northwest portion of the Las Vegas Valley, and also as the Senate Majority Leader. And I am so pleased to be here with you this morning to present to you Senate Bill 190, which will allow women to access birth control in the state of Nevada without a prior prescription from their doctor and while being covered by their insurance. Some of you may remember hearing this bill in part from last session. It was a Senate bill last session that this committee heard and that the Senate was able to get through, but we lost time in the end of the legislative session. And so I am back again for a second time to try to improve access to essential health care for women. As I mentioned, birth control is what we would consider essential healthcare, and SB 190 will work to eliminate more barriers to access in Nevada and level the playing field for women. Some women may have to wait months before they can get an appointment with their OB/GYN in order to get a prescription for birth control. Other women may lack regular access to transportation to go to and from doctor's appointments, limiting their ability to obtain a prescription. And for so many Nevada women, the barrier lies in juggling multiple roles, including providing care for family members, working and assisting with their kids' education. And all of these I mentioned because these are reasons for why it is so essential that we open up access for women to get what we know to be safe forms of birth. None of these things that I have mentioned should mean that women have to forego caring for their own health and well-being due to lack of access to contraceptives. Studies show that 99% of sexually active women have used a form of birth control at some point in their life. And we do so for varying reasons, whether it be to finish our education, obtain a career goal, or simply to wait to have a family for when we are ready. Birth control empowers women to make decisions that are right for our own bodies. Medical research also supports this, and I would note that we do have a number of exhibits that I'll touch on very briefly that have been uploaded to Nellis for the committee's perusal and for the public as well. From treating acne to ovarian cysts, birth control has been prescribed to millions of women to benefit our health. And over the course of decades, research compiled shows that access to birth control has a direct link to reduced infant and maternal mortalities. This is part of the reason why the American College of Obstetricians and Gynecologists supports allowing pharmacists to dispense contraceptives in order to increase access. And this is also why I am here today to present Senate Bill 190. This bill is a result of hours of conversations with medical experts from across the state and country. One of those experts is Dr. Sandra Koch, an obstetrician with over 30 years of medical experience. Dr. Koch is here with us today, and before I explain the bill, I would like, Madam Chair, with your permission, to allow Dr. Koch to provide testimony on the importance of pharmacist-provided hormonal birth control.
Yes, ma'am, please proceed.
Hi, as she mentioned, I'm an OBGYN. I'm here representing the Nevada State Medical Association and the American College of OBGYN. I've been practicing in Carson City for over 30 years. I want to speak about pharmacists dispensing of hormonal birth control. And just to make that clear, what that means are birth control methods that women take themselves. So they're self-administered that contain either progestogen or progestogen and an estrogen component. The effort to make access to these types of contraceptives more available to women by making them over the counter began over a decade ago and has the support of the American College of OBGYNs, the American Medical Association, and many other national medical and nursing organizations. In its review, the FDA found that hormonal contraceptives are very safe. Progesterone-only methods really have extremely rare contraindications, and estrogen-containing methods, major risk is an increase in blood class that applies to a very small subset of women. Multiple studies have demonstrated that these women at high risk can use a simple health screening questionnaire in a very successful manner to identify themselves. Current US law requires patients to have an appointment with a healthcare provider to start or continue contraception. Unfortunately, that is a barrier, and some women can't obtain a prescription or they can't refill and end up with unplanned pregnancies. The FDA has not approved any hormonal contraceptives at this time for over-the-counter use. Allowing pharmacists to dispense these contraceptives with the assistance of a self-administered screening questionnaire is a step in the right direction, making these contraceptives more available to women. Pharmacy access to hormonal contraception means women could go into a pharmacy, fill out a questionnaire, check their blood pressure, and then request and receive their choice of a safe method to prevent pregnancy. Based on the answers to the questionnaire, they could choose between birth control pills, a birth control patch, or birth control rings. Clearly, this will make it easier for some women to obtain them. Some people worry that women who obtain birth control from pharmacists won't get recommended preventative care if they do not have to see a provider to get that birth control. There was a study done in comparing women in Texas to those in Mexico. In Mexico, they don't need to obtain a prescription. They can just go into the store and purchase them. And in Texas, they need a prescription. And they showed that there was actually good rate of receiving preventative measures in both preventative health screens in both populations. We OBGYNs still recommend that women see their doctors regularly or the healthcare providers. However, delaying or missing an appointment should not be a reason for women to be denied contraception. I strongly support passing this measure and giving women one more tool to control their fertility. Thank you all very much for your time.
Thank you, Madam Chair, for your indulgence, Doctor. With your indulgence, Madam Chair, I would like to walk through some sections of the bill at this time. As you and the members of this committee are aware, Senate Bill 190 requires the state's chief medical officer to issue a standing order that allows pharmacists to dispense birth control to women in Nevada. Currently, 13 states and the District of Columbia have similar laws allowing pharmacists to provide birth control without a prior prescription, whether through a standing order, practice protocols, or by expanding their scope of practice. I'm going to discuss each of the bill's sections a little slightly out of order, beginning with Section 8, which requires the state's chief medical officer or his or her designee to issue a standing order allowing pharmacists to dispense a self-administered hormonal contraceptive to any patient. The State Board of Health must work with the chief medical officer to adopt regulations establishing a protocol for dispensing these contraceptives, and with the State Board of Pharmacy to adopt regulations prescribing the following: a risk assessment questionnaire that may be administered upon request to a patient who requests such a self-administered hormonal contraceptive, and the information that must be provided in writing to these patients. Section 8 also requires the Division of Public and Behavioral Health to post on its website a link to the list of pharmacies that dispense contraceptives as authorized by this bill. Going back to Section 3, this section allows a pharmacist to dispense a self-administered hormonal contraceptive under the chief medical officer's standing order, regardless of whether the patient has obtained a prescription from a practitioner. Before a pharmacist may dispense a contraceptive, they must provide the risk assessment questionnaire to any patient who requests it. If the results of the questionnaire indicate that it is unsafe to dispense the self-administered hormonal contraceptive, a pharmacist may not dispense the contraceptive to the patient and must refer the patient to their healthcare provider. Additionally, pharmacists must create and maintain a record of each person to whom a self-administered hormonal contraceptive is dispensed, including the name, the drug dispensed, and other relevant information required by the protocol. Pharmacists must also inform patients of proper administration and storage of the contraceptive, potential side effects, and the need to use other methods of contraceptive if appropriate. Certain written records related to the request or dispensing of self-administered contraceptives must also be provided to patients, regardless of whether a contraceptive is dispensed. Finally, any pharmacy wishing to dispense self-administered hormonal contraceptives is required to notify the State Board of Health. Sections 5 and 6 amend the scope of practice of a pharmacy to include dispensing of self-administered hormonal contraceptives and authorize the State Board of Pharmacy to suspend or revoke a certificate to practice as a registered pharmacist if the pharmacist dispenses such contraceptives without complying with the provisions of Section 3. Finally, Section 7 and Sections 9 through 15 require certain health insurers, including Medicaid and state and local governmental employer-based plans, among others, to cover self-administered hormonal contraceptives dispensed by a pharmacist. What I would like to note about the provisions of this bill is that we have worked to ensure that there are safety protocols so that women who may need to see a practitioner are in fact referred to that practitioner. And also the important key part is ensuring that insurance, regardless of whether you receive that prescription from your practitioner or from the pharmacist, will cover that prescription the same as it would if the woman were to go and see a practitioner and receive that prescription. And so that's the primary focus of not only some of these sections I've described, but also of the pieces that relate to insurance. Chair Spearman, this concludes my explanation of the bill. And as I mentioned, Senate Bill 190 is essential in allowing Nevada women to have easier access to birth control. And I definitely urge everyone's support. I'm happy to take questions from you or members of the committee. And before that, I did want to just note that there are several documents that deal with a number of studies that have occurred, recommendations from different healthcare providers and boards that talk about what we're dealing with here in terms of the pharmacists allowing to dispense contraceptives. There are several documents related to those. They're all on Nellis for everyone, and they are mentioned there with Dr. Koch's name. Those have been submitted by both herself and me for the committee's consideration as some background information. Thank you, Madam Chair, and I'm happy to take questions.
Thank you, Majority Leader. I'm going to take a point of privilege because I've got to step out to testify over in the Assembly, metaphorically. So I want to take a couple of questions just before I open it up to the committee. One of the things that I imagine this can do is help women who are in rural and frontier communities. Can you speak a little bit to that in terms of access, continued access?
Yes, thank you, Madam Chair. And to you, I appreciate the question because I think that is a very critical piece of this. What Senate Bill 190 is really seeking to do is to remove barriers to access for what we know to be safe, usable hormonal contraceptives. And so for women who are in rural communities or who maybe have to go a long distance in order to see a practitioner just to get that prescription for a medication that we know to be safe, that we know to be able to be administered by the patient, and that we know many women are having to make that additional step for, and then also go to a pharmacy in order to get that filled. We're removing that barrier of access and allowing them to have that easy access to hormonal contraceptives. That would also, I think, apply to women who are in areas where it is difficult to find transportation, either because of their role in nature or because that woman lives in a place where transportation is hard to come by. Lower income areas definitely would fall into that category. And so by removing this barrier, we are opening up that access that really does play, I think, into the overall women's health conversation. We know that this can help to reduce, and as I mentioned, fetal and maternal mortalities. It also allows for women to have better control over their own healthcare decisions. And in addition, one thing I think that's worth pointing out, because this has come up in conversations, nothing about Senate Bill 190 says that women are going to stop going to an OBGYN. It doesn't mean that we are going to stop continuing to take care of ourselves, because there are a number of other services that we have at our OBGYN offices. This is strictly related to hormonal birth control. And as I mentioned, if there is a complication or something in the woman's history or their healthcare background that would require for them to really see a practitioner before it would be safe to administer that hormonal contraceptive, that would be flagged within those questionnaires. And again, I would reference the documents that we've provided on Nellis that talk a little bit about the safety of those questionnaires.
Thank you for that, ma'am. So I saw Vice Chair Neal's hand first, and I'm going to call on her. And when you finish with your question, I'm turning the gavel over to you.
Okay, thank you, Madam Chair. So I have a question on the, there's two questions in section 3. The questionnaire, and I looked at that study that was uploaded in the record in the exhibits, but what I'm not clear on is the study was done in the UK. The results talked about open-ended or closed questions. What would be in the questionnaire that would be here? Because it said that the self-assessment could potentially not address all of the risk factors that are needed. That was in the result of the study on the questionnaire.
Thank you, Madam Vice Chair. Through you to the committee, that's a great question. And Senate Bill 190 doesn't prescribe the exact questions that would be included in the questionnaire. Rather, Senate Bill 190 in Section 8 allows for the State Board of Health to work with the Chief Medical Officer and the State Board of Pharmacy that would adopt the regulations to include what would be contained within that questionnaire, what information must be provided to the patients, so that we are asking the right questions and getting that information. So that is not prescriptive within the language of the bill, but would be left to those with the best medical expertise to determine how best to word those questions, be they open-ended or closed, and to what extent we're gonna be asking those questions of the patient, so that we can catch kind of all of those different facets that may play into whether it is safe to administer hormonal birth control.
Okay. And then it's the second question in section 3, which is on line 27. It said, this is about creating the record of what was dispensed and how it was disposed of, et cetera. But in that line 27, it says the pharmacist or his or her employer shall maintain the record. So I wanted to get an understanding on like the employer, because in these scenarios, that could be a Walgreens, that could be a CVS. So is there a confidentiality issue? The employer storing it, and should there be some other mechanism in place?
Thank you, Madam Vice Chair, and through you to the committee, and that's a great question. We've added this language because I do think that it is consistent with, if you go to Walgreens, and if you've ever had, for example, strep throat, and you got amoxicillin from Walgreens, the next time you go there, they may have a record of that as well. So I believe this to be consistent with what is current practice if you are a patient there, for the pharmacist to keep that record and for the pharmacy to have that. And one of the pieces and the reasons why we wanted to make sure that there was a record was because for women who may be going and refilling prescriptions, who've filled out a questionnaire previously, we want to make sure that we have all of that information so that there's a comprehensive record that they can refer to when deciding whether or not it is safe to actually administer the hormonal contraceptive. But I do believe that that is consistent with current practice with pharmacists.
Thank you, Madam Chair.
Thank you. I saw Senator Hardy's hand next, and Senator Scheibel, and then Senator Pickard.
Thank you, Madam Chair. I may have misheard, but in testimony I heard if there's a risk, then may not dispense, but the language in the bill is very clear, must not dispense. So the pharmacist doesn't get trapped in a, well, please, please, please. So the pharmacist should not, must not dispense if there's a risk factor. Speaking of the risk factors change. So how long is the prescription for, or in as much as it's a semi-prescription, how long is the prescription for, and how often is the questionnaire renewed or asked and kept a record?
Thank you, Senator Hardy. Through you, Madam Chair and Madam Vice Chair, to the Senator. Those are both great questions. First, with respect to the may versus must, that was likely just my own wording, and the language in the bill is must. Our intention in this is that if there is something in that risk questionnaire, it would not be safe for a pharmacist to dispense the hormonal birth control. There is no mechanism by which they can then override that and administer the hormonal contraceptive. Rather, the mechanism is to refer them to a practitioner who can do a more thorough evaluation of whether there may be another safer form of hormonal birth control or other contraceptive. So that is clear in the language of the bill, as you mentioned, the word must, and that is the intent. This is meant, most women will not fall within that category, will be administered the hormonal birth control, but there are those who do need to see a practitioner. We know that from just common practice, and so we want to make sure that that is still the case. With respect to the risk factors and how they change, currently with, I want to say it was in 2017, and Senator, you may remember better than I, that we did pass legislation that allowed for 12 months of birth control to be dispensed at once. Previously, it had been 3 months, so they were talking about appointments every every quarter rather, in order to fulfill that 12-month prescription. But we do have legislation now that would allow for that 12 months. This doesn't change that, so they could receive up to the 12 months. And then, of course, we are endeavoring to ensure that that risk assessment is done whenever they come in to fill that prescription. But again, I think that is left to the regulations with the state Board of Health.
So your intent is to have the questionnaire at least every 12 months?
Thank you, Senator Hardy, for the question. Through you, Madam Chair and Madam Vice Chair, to the Senator. Yes, at least that way we can ensure that if risk factors have changed due to some other health issue that has come up or a change in their own behavior, that the patient is properly evaluated.
I appreciate you bringing the bill. I think it's been a long time coming. Thank you.
Now, and Majority Leader, just go direct. Ask him to go direct, okay?
Okay, so next, Senator Scheibel.
Thank you. I have 2 questions, if that's okay, and also a comment, which is that I love this bill, and I think that it is incredibly important and great public policy I think that requiring a prescription for birth control makes about as much sense as requiring a prescription for a condom, especially when I can buy like 1,000 pounds of ibuprofen at a time at the pharmacy. So what I wanted to ask is 2 things. First of all, I want to check my understanding on what I see as one of the advantages of this bill, which is that if I go to my doctor tomorrow and I say, hey, the birth control that I'm currently on isn't working for me. I have to take it every single night. I don't remember to take it. I need something that is more flexible. And I say, but I'm not sure if I want the ring or the patch. Then my doctor doesn't have to prescribe one, have me go try it, come back, say, hey, the patch was itchy. I actually want to try the ring after all, prescribe it, go back to the pharmacy. it would allow me to go to the pharmacy and get the patch and use it for a month or two. And if I don't like it, having already had the conversation with my doctor who agreed that I could utilize either one, I can go back to the pharmacy by myself without making another appointment with my doctor and get the ring instead.
Thank you, Senator Scheibel, for the question. And I think you've kind of touched on a couple of things that bring up when folks have concerns about this bill. And I definitely appreciate your understanding of some of the things that women go through just trying to manage some of their own healthcare. I think what we are endeavoring to do with this, and one of the things that I think you touched on, which is important to note, is that where there is an issue with a form of birth control, we want a woman to go and see their OBGYN. You get, an additional in-depth conversation with their practitioner to ensure that what's going on with their health is potentially something like you mentioned, where maybe it's just that you can't remember to take it at the same time every single day, which is not necessarily if there's an issue with the prescription, but that there may be an issue where that's just not feasible for the patient and their lifestyle. But for instances where you mentioned, for example, having received the patch, maybe it's itchy and you might be having an allergic reaction, I think that would be the kind of event that would trigger within the questionnaire, and we would hope would trigger within the questionnaire to have a woman go and talk with their practitioner just to get that additional follow-up. But in essence, if a woman were to maybe not go see their practitioner, wanted to get on birth control, that is something where the pharmacist can certainly dispense that. And of course, some of this is going to be regulated with respect to the questionnaire and the pharmacist being able to feel comfortable in what it is that they are prescribing as well. So obviously, I think one of the most important pieces of this bill is this does not in any way, if you are a woman who does go to their OBGYN for a prescription, and that is where you would like to get your prescription, you can do that. If, on the other hand, you're going to your OBGYN, you're getting your pap smears, you're getting your other tests that are done with your OBGYN to check your general health, but you at some point decide you would like to go into hormonal birth control, you can absolutely walk into the pharmacist without a prescription, fill out that questionnaire, and absent any red flags that come up with your own personal health history, that would be immediately dispensed to you without having to then schedule yet another appointment with your OBGYN, hope to get in within whatever that time frame is, and then get that same prescription that we know is safe enough to do with the pharmacist.
And you brought up another point in answering my question that you made me think. That also means that if I go back to Las Vegas during session and I forget my birth control up north, I can go to a pharmacy down south and pick up a new one and not miss 3-4 days of treatment and risk an unplanned pregnancy.
Thank you, Senator Scheibel. Yes, there's nothing in the bill that would prevent you from, that would be intended to prevent any woman from seeking that birth control from the pharmacy.
And my last question has to do with the future of this standing order for the medical officer, the chief medical officer, and what happens in future years. We have a different administration, there's someone else in that position. Is this subject to change?
Thank you, Senator Scheibel, and that's a great question that has come up in these conversations and through our work last session and this session. That has been a point that we've looked into, and that's why the language in the bill requires for the state, for the chief medical officer to have the standing order, so that we know this is policy that the legislature supports, that we want here in the state, and even with a change in administration, that standing order would still be required.
Thank you again for bringing the bill and answering all my questions.
Okay, thank you. So members, any additional questions? Okay, I don't see any hands raised. All right, so we will move to support for SB 190. EPS, is anyone on the line? And we'll have 20 minutes.
Chair.
20 minutes for support, 20 minutes for opposition, neutral.
Thank you, Chair. Vice Chair, I'm sorry. To testify in support of SB 190, please press *9 now to take your place in the queue. Caller with the last three digits of 550. Please slowly spell and state your name for the record. You will have 3 minutes and may begin. Caller with the last three digits of 550. Please press *6 to unmute yourself. You may begin. Caller with the last three digits of 550. Please press *6 one more time. Please begin.
Good morning. My name is Ann Silver, ANNSILVER, and I serve as the CEO of the Reno Sparks Chamber of Commerce. Good morning, Vice Chair and members of the Committee on Commerce and Labor. Our organization fully supports Senate Bill 190 as part of its long-standing commitment to the rights of women and their ability to secure contraceptives without a lengthy and often intimidating process. By making access to contraceptives easier and more efficient, women will be better able to continue multitasking as parents by choice, professionals, and effective community participants. We thank Senate Majority Leader Canizaro and all the sponsors of this legislation and urge swift passage of Senate Bill 190 as evidence of your support for women in Nevada. Thank you for your time.
Okay, next.
Caller with the last three digits of 130. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Chair and members of the committee. For the record, my name is Christine Saunders. That's CHRISTINESAUNDERS, and I'm Policy Director with Progressive Leadership Alliance in Nevada, here in support of Senate Bill 190. Access to contraception is a much broader issue than just pregnancy prevention. When we expand access to birth control, we expand women's economic opportunities. SB 190 will help ensure that all women, particularly marginalized communities who lack access to stable and affordable health care, have autonomy over their reproductive health and futures. We urge your support.
Caller with the last three digits of 956. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, and thank you, Chair. For the record, this is Liz Davenport, LIZDAVENPORT, the legal intern for the ACLU of Nevada, here in support of SB 190. Thank you, Majority Leader Canizaro, for bringing this bill. Removing barriers to accessing birth control has broad positive impacts in economics, in educational opportunities, in racial justice, and others. Difficulty accessing birth control disproportionately affects Black women and other people of color. Black women are more than 3 times as likely to have some conditions that are often treated with hormonal birth control, and removing a barrier to accessing birth control can only benefit all communities. Further, education-wise, multiple studies have shown access to birth control is one of the most influential factors in enabling women to stay in college and has been linked to a 20% increase in enrollment and a 35% decrease in dropout rates. Additionally, Bloomberg Businessweek has listed contraceptives as one of the most transformational developments in the business sector in the last 85 years. It has helped narrow the wage gap between men and women. Removing barriers to accessing birth control removes barriers to education, jobs, and healthcare. We support SB 190. Thank you, and that concludes my testimony.
Caller with the last three digits of 932. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Madam Chair and members of the committee. For the record, my name is Victoria Ruiz Marin, VICTORIA-RUIZ-MARIN. I am a community organizer with Planned Parenthood Votes Nevada and a member of the community in Las Vegas. Planned Parenthood Votes Nevada is in favor of Senate Bill 190. Allowing pharmacists to prescribe birth control is crucial to increasing access to a foundational component of sexual and reproductive health care. Birth control has been key to improving women's health, social and economic conditions, and preventing pregnancy since its inception. The ability to plan your parenthood can profoundly affect your ability to pursue a career, work, and other opportunities. Additionally, birth control is essential to treat certain health conditions. Access to birth control helps mitigate the barriers for communities of color and low income who already experience disproportionate maternal mortality rates and health disparities that the COVID-19 pandemic has exacerbated. Allowing pharmacists to prescribe birth control will help give Nevadans autonomy over their health. I urge to support Senate Bill 190. This concludes my testimony. Thank you.
Caller with the last three digits of 540. Please slowly spell and state your name for the record. You have 2 minutes and may begin.
Good morning, Vice Chair, members of the committee. For the record, my name is Serena Evans, SERENA-EVAMS, and I'm the Policy Specialist for the Nevada Coalition to End Domestic and Sexual Violence, and we're here today in support of Senate Bill 190. Having easy and affordable access to birth control is important for everyone, especially victim survivors of domestic and sexual violence. Accessing healthcare is a challenge for many Nevadans, and for victim survivors who are constantly surveyed by their perpetrator, accessing a healthcare professional to get access to a birth control prescription is not always feasible or safe. In some instances, perpetrators will accompany the victim survivor to every doctor appointment to assert power and control and to sabotage their use of birth control. Being able to access birth control over the counter at a pharmacy may allow a victim survivor the much needed accessibility to be able to access birth control and to prevent unwanted pregnancies with their perpetrator. Allowing people to access birth control from pharmacists directly will greatly increase barriers for so many Nevadans and can have positive and important impacts for victim survivors. Thank you.
Caller with the last three digits of 729. Please slowly spell and state your name for the record. You have 2 minutes and may begin. Caller with the last three digits of 729. Please press *6 now to unmute yourself.
Sorry about that. My name's Caroline Mello-Robertson. I'm the Southwest Regional Director for NARAL Pro-Choice America. That's CAROLINE-MELLOROBERSON. I submitted comments on the record, so folks can check it out on Nellis. I'll just summarize since a lot of what I've said has already been covered. But NARAL Pro-Choice Nevada is very proud to be in support of SB 190 as we were in 2019. We know that for birth control to be effective, consistency and timing is essential. And this legislation will do much to increase access to birth control for Nevadans. Thank you for your time.
Caller with the last three digits of 283. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
MARCOS-LOPZ, Marcos Lopez, Americans for Prosperity, Nevada. We are in support of SB 190. It will definitely increase access for birth control for individuals who lack health insurance, a primary care doctor, and it will save taxpayers money. The cost of unintended pregnancies cost taxpayers around $102 million annually. And currently, there are already 13 states in D.C. that already empower pharmacists to do this. Ideally, the FDA would allow these birth control products to be sold over the counter, something that the majority of countries in the world already do. But SB 190 will do great benefits to both women who lack health insurance, live in rural areas where they might have less access to healthcare, OBGYNs. Everyone knows that pharmacy checkups, visits are quicker, easier, and more accessible than scheduling a doctor's appointment. There is a 2016 study that was survey that was published in National Library of Medicine that showed that nearly a third of women reported difficulty obtaining prescriptions. And the number one reason they said it was scheduling and getting to their appointments. So we hope that everyone please support this legislation. Thank you.
If you recently just joined us, we are currently in support of SB 190. To testify in support, please press *9 now to take your place in the queue. Caller with the last three digits of 005, please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 005, please press *6 now to unmute yourself.
Hello, Madam Chair Spearman and the Senate and Commerce and Labor Committee. My name is Ken Kunke, Kenkunke, and I am here today representing the Nevada Pharmacy Alliance. We are an organization that represents pharmacy professionals that work all over our state. We are excited to expand our ability to be able to take care of patients, and I'm here to show our support of Senate Bill 190. Nationally, 68% of women report barriers to acquiring contraceptive care in the United States. While this number is concerning, there are steps that we can take to improve this number. Currently, 12 states have laws in place that allow pharmacists to be able to prescribe hormonal contraceptives, and they are proving that this process works. A study out of California and Oregon have shown a reduction of unintended pregnancies since this type of law has been passed. 74% of women who received hormonal contraceptives from a pharmacist report that they had no use of birth control in the previous 6 months. This doesn't surprise me. Pharmacists are the most accessible healthcare professional, and they are able to provide services like this to patients throughout Nevada. 90% live in a 5-mile radius of a pharmacy, and patient consultations are a normal part of a pharmacist's day. Today, I ask you to also show support in passing Senate Bill 190 so that pharmacy teams can start providing access to hormonal contraceptives in Nevada.
Okay, thank you for your testimony. Mr. Porath, are you trying to speak in support of SB 190? I see your hand raised. Is that an?
I am.
Oh, okay.
Thank you. For the record, Adam Porath, Nevada Society of Health System Pharmacists. I am in support of this bill. As Ken just said, I think from the pharmacist perspective, we are ready and willing to help in this space. There was a survey done nationally. Over 85% of pharmacists are interested in providing this sort of service for our patients. So strongly support this bill.
Okay, thank you for that. BPS, can you go back to the phone line and see who else is in support?
Absolutely. We are currently in support of SB 190. To testify in support, please press *9 now to take your place in the queue. Caller with the last 3 digits of 893, please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits of 893, please press *6 now to unmute yourself. You may begin.
Good morning. My name is Vasudha Gupta, Vasudha, last name Gupta, Gupta. I am an associate professor at Roseman University College of Pharmacy and a board-certified clinical pharmacist at a federally qualified health center in Henderson. I'm representing the Nevada Pharmacy Alliance, and we fully support Senate Bill 190. Pharmacists have a doctorate degree focused on medication management, are highly trained professionals, but unfortunately are underutilized. Pharmacists being able to prescribe safe and effective hormonal contraceptive medications will significantly improve access to care to women who want to prevent pregnancy, along with allowing pharmacists to have discussions with patients about safe sex practices. SB 190 will help to reduce unintended pregnancies and decrease the burden on our healthcare system. The most important thing that I wanted to mention that has not been touched upon so far is insurance coverage. I can't tell you how many times I have dealt with this personally as a patient and as well as a healthcare provider. With our healthcare system, insurance provider coverage changes constantly and medications are often not covered. What typically happens is one prescription is sent to the pharmacy, it's not covered, and then the patients have to call the provider back and then check back with the pharmacy to see whether that medication is covered. And this may occur several times before finally determining which medication is actually going to be covered by the insurance provider, which could delay access by weeks for the patient and cause unnecessary burden to both patients as well as the provider offices. If the entire process is done at the pharmacy, it's easy for the pharmacist to determine which prescription will be covered, and it can be dispensed then and there for the patient to make the process a whole heck of a lot easier. I appreciate the opportunity to speak. Thank you so much.
Caller with the last 3 digits. Oh, I'm sorry, Vice Chair.
No.
Of 019. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits of 019. You may begin. Caller with the last three digits of 019. We can see you are unmuted. Please begin speaking.
Sorry about that. Good morning, Madam Chair and members of the committee. My name is Michael Moini. That's Michael and I'm a Community Engagement Director for Americans for Prosperity. Now, the driving ideology behind Americans for Prosperity lies in removing barriers and empowering citizens, and we believe SB 190 accomplishes both. Women have a right to purchase contraceptives without government either forcing them to obtain a doctor's permission or increasing the price of their birth control. Now, there's a myriad of reasons why someone may not have access to an OBGYN, but do have access to a local pharmacy. And as a father of two young girls, I believe my daughters have the same right to easy access to birth control and being in charge of their reproductive futures as someone else's sons. So thank you, Senator Canizaro, for bringing forth this bill, and thank you, Madam Chair and the committee, for your time.
Okay, so thank you. I just want to let the callers know that are on the line, we have 5 minutes left for the 20 minutes for support before we move.
Caller with the last three digits of 11199. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Chair and members of the committee. My name is Tess Opferman, that's OPSERMAN, speaking on behalf of the Nevada Women's Lobby. First, I want to thank Senator Canizaro for her hard work on such important legislation. We echo what those before me have said this morning. SB 190 is critical to creating easy access to birth control, ensuring women are able to make decisions about their bodies and their futures. Allowing pharmacists to distribute birth control means women can easily access their necessary preventative birth methods without doctor's appointments and without insurance. This is a huge step for women's health, and we are in full support of this measure. We ask you to support this legislation, and thank you for your time hearing this bill this morning.
Caller with the last three digits of 643. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 643. We can see you are unmuted. Please begin. Moving on to the next caller. Caller with the last three digits of 967. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning. For the record, my name is Laniqua McLeod, Laniqua, last name McLeod, MCCLOUD. I want to thank everyone. And I just want to say that I'm in support of the current bill, AB 160, as it applies to us having more options and availability with getting contraceptives over the counter. I believe that it is solely in our best interest that women have that personal optional choice, and that is kind of that power is given back to us as women. So I want to thank you, and I hope you will be in support as well.
Caller with the last three digits of 456. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Yes, good morning. My name is Kaylin Bowman, KAYLYNN, BOWMAN, and I'm here representing myself as a licensed pharmacist practicing in Nevada for 14 years. The legislation proposed in this bill will improve timely and equitable access to hormonal contraceptives to women in Nevada. Pharmacists are trusted members of the healthcare community, easily accessible and readily available to meet patient needs for not just medications, but for other healthcare needs. How will the Senate bill for prescribing hormonal contraceptives in the pharmacy look to me? Based on my past experiences, here are some issues that I've run into. We're ringing up Plan B emergency contraceptives. We can have a conversation now about getting on more consistent birth control and lower the risk for unwanted pregnancies. When a young college student does not have a provider or health insurance and is seeking information on how to get care, I can get her started on hormonal contraceptives and give her a provider referral. When a woman is out of refills and it's the weekend, I can then provide her with additional medication, thereby reducing the chance for missed doses. Overall, pharmacists are practicing in a dynamically changing healthcare environment, and we have to progress forward to working collaboratively and effectively to improve patient care. And that is why today I am asking for your support for Senate Bill 190. Thank you.
Vice Chair, we have one left in support. Would you like to hear that testimony?
Yes, we'll go ahead and hear that, and then that will be the last person in support.
Thank you. Caller with the last three digits of 898. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, members of the committee. For the record, my name is Annette Magnus, and I'm here today in support of SB 190. I am also the Executive Director of Battleborn Progress, but today I'm here in my personal capacity. Just last weekend, I had an experience with my own birth control where I was not able to renew my prescription. I cycle my pills because I have horrific periods, I have horrific migraines, and I have to take my pills differently as prescribed by my doctor. I've been doing this for years to control my migraines, to control my periods and my cramps. And last weekend, my birth control ran out. I called the pharmacy to renew my prescription. And because of the way I take my pills, I always run out of my prescription early, and my insurance won't cover more. And so I have to call my doctor. I have to get it reauthorized by the insurance. I have to go through 100 different steps. Now, I am lucky. I have the privilege to know those steps. I worked for a healthcare provider, so I understand the process. But another woman might not. She might not have that privilege that I have to navigate that system. And I'll tell you, because I had to navigate that system, I then missed almost 5 days of pills, and then I started my period and had a horrific migraine. And there is no medical reason for any of that I should have had happen. I've been doing this with my pills for years. I should have been able to walk into the pharmacy, have the pharmacist renew my prescription, and have that conversation directly with the pharmacist so I didn't have to go through the things that I did. And so my ask of you today is to pass this bill. There are thousands of people who take birth control in this state who are counting on you to make it easier and more accessible. Again, many of them don't have the privilege that I have to know how to navigate that system when it's medically necessary, but other people need this medication. They need this medication to be able to control their fertility and control their medical needs. And so I'm asking you today to pass this bill for the millions of for the thousands of Nevadans who are counting on you, because this is medicine and they need access to it. Thank you so much. And thank you to Senator Cannizzaro for bringing this bill. It's very personal to me.
Thank you. So we will go ahead and shift to anyone who is calling in opposition to SB 190.
Thank you. We are currently taking opposition on SB 190. To testify in opposition, please press *9 now to take your place in the queue. Again, we are currently in opposition of SB 190. To testify in opposition, please press *9 now to take your place in the queue. Vice Chair, you have no callers in opposition at this time.
Okay, thank you for that. Anyone who has called in neutral position?
To testify neutral on SB 190, please press *9 now to take your place in the queue. Again, to testify neutral on SB 190, please press *9 now to take your place in the queue. Chair, you have no callers neutral at this time.
Okay, thank you for that. Members, do you have any final questions before we close out this hearing on SB 190? So Majority Leader Cannizzaro, I just have one quick question on the bill. So pharmacists have an MPI, like they're actually listed as providers. Will this allow pharmacists who are now engaging in extra activity to have a profit, or as a provider as they dispense these medications? or will it go into their employer's fee structure?
Thank you, Madam Vice Chair, for the question. I don't know that I have an answer on that. I guess I'll touch on two different things. One, the bill would allow for obviously the pharmacist to have that expanded scope of practice to allow them to prescribe the birth control. I'm not sure what effect that would have on your direct question. One thing I would note about this bill is, and we were careful certainly in crafting this and had several conversations about this, was not attempting to charge an additional fee for the pharmacist to provide the birth control. We wanted to make sure it was covered by insurance, and we wanted to make sure that there wasn't going to be an additional charge or mechanism such that it might become cost prohibitive for women to use this as a form of access. But I can certainly get a final answer to that question.
Okay, thank you for that. And I see Senator Hardy's hand. Senator Hardy.
Thank you, Madam Chair. I appreciate all of the testimony. Obviously, the phraseology is any patient, and hopefully there's some kind of recognition that this will probably prevent people from getting pregnant and having abortions, for instance, at whatever age they become able to have a period. But I think it's optimistic that we will have patients still continue to have pap smears and other screenings done as often as they do now. But nonetheless, I think the overall in the balance will create an ability for people to access care and prevent other things that will require them to have adverse effects on their health. So in the balance, I think it's a good thing, but there are downsides to it that I think all of us are probably going to be aware of. Thank you, Madam Vice Chair.
Okay, thank you for that. So, Majority Leader, I don't know if you have any comments towards that or if you want to move towards closing comments.
Thank you, Madam Vice Chair, and I will briefly just address Senator Hardy's comments because I think that that's something that we definitely hear. And I will say this, we as women go to the OBGYN for a variety of reasons, not the least of which is to obtain birth control. And certainly some forms of birth control, even under this bill, will have to be administered with the consultation and with going to your OBGYN. Things like an IUD, they require that physical component are not what a pharmacist would be prescribing or inserting into a patient. So, this bill is not meant to say that we don't want people to continue to see their OBGYNs for regular checkups. And I think what we need to do a better job of, not only as a legislature, but as a society and in our communities, is trusting women with their own healthcare, such that we can make sure that the message about making sure you get pap smears, making sure that you are getting breast exams, making sure that you are taking care of your health in those ways, in addition to having easier access to birth control, are still paramount. We trust patients all the time. If you have a cold and get Theraflu from the local Walgreens, we don't believe that those patients aren't going to go and see a doctor if they get sick a second time from something, right? We trust patients to be able to see their practitioners. We should be promoting that, and we should be trusting women with their own health care. I think if anything, then maybe we need to do a better job of ensuring that women know that you have to go and get regular pap smears in order to catch different types of issues that may arise, that you have to be doing breast exams. And I don't think that this diminishes that, and we shouldn't be putting up barriers for women to obtain contraceptive on the premise that that's what's going to encourage them to go and get a pap smear. I think if anything, when you have barriers to birth control, it doesn't necessitate that women are going to see their OBGYN. It sometimes just means they go without healthcare. So if we can remove one of those barriers, I think that's the important crux. And I definitely appreciate Senator Hardy bringing that to light, because I think that's an important point that we definitely heard in the course of this conversation. In closing, I just wanted to thank members of the committee for allowing me to present this bill. Again, I very passionately believe that this is something that we must do to help expand access to women's care. And it's something that really can help to not only allow women to make those choices for themselves. This is something that we know to be safe. This is something that we know can be administered properly by our pharmacists. This is something that I think is going to reduce those barriers and help with fetal and maternal mortalities. It is going to help address some of the issues that we have with unintended pregnancies. And so these are the kinds of questions that I think are at the forefront of this bill and what it is intended to get at. And I appreciate the committee allowing me to be here today to present this.
Okay, thank you, Majority Leader. All right, so we will go ahead and close the hearing for SB 190. And we will then open up the hearing on SB 198.
And thank you, Madam Vice Chair Neal, and members of the committee. Back for round 2 today. I'm here to present to you Senate Bill 198. And again, I am Nicole Canizaro. I represent Senate District 6 in the northwest portion of the Las Vegas Valley, and also serve as a Senate Majority Leader. And I'm grateful for the opportunity to be here with you today to talk about what I believe to be an important topic of conversation, which is contained within Senate Bill 198, where we are seeking to regulate earned wage access providers by limiting their ability to not only sell personal information, but also ensuring that there are sufficient consumer protections for consumers who may wish to be utilizing these types of applications. By way of background information, I think one of the reasons why this is a pertinent conversation relates directly to what we're seeing in so many of our own communities. So many people are still struggling financially right now as a result of the pandemic. But even before that, we know that there are so many Nevadans that really do live paycheck to paycheck. For these workers, the slightest unplanned event, often common life occurrences, could upend their financial stability. A child gets sick and needs to go to the hospital. A prescription needs refilling. A car breaks down or gets a flat tire. And so for Nevadans living on a tight budget, everyday events like these can be difficult to navigate, particularly if they find themselves in the middle of a pay period. Having grown up in a family where we definitely lived very much paycheck to paycheck, having done that myself prior to getting to a point of my current career, it can be very devastating for even the smallest life event. And sometimes it is the difference of asking for just a little bit of money from folks in order to not overdraft your checking account. And I have definitely been in that situation, and I've watched my parents in that situation where we've asked for change to literally go to the bank and fill up a bank account just to avoid getting an overdraft fee. These are the kinds of things that everyday Nevadans face. And one of the ways in which they are seeking to solve this is with some of these earned income applications. Research shows that more than 3/4 of full-time workers in the United States also live paycheck to paycheck. Now, new earned wage access applications allow people to request and to receive wages as they earn them. As life's unexpected events arise, workers now have the ability to access the money they have already made instead of struggling to get by, overdrafting their accounts and paying large compounded overdraft fees or turning to high interest payday loans just to make it through. Earned wage access enables employees to receive their wages before their next normally scheduled payday and to take home either one day's wages or all the money they earned during that pay period thus far. Earned wage access began with the development of the gig economy, but this interest has spread to employers and employees in what we would refer to as traditional businesses. In 2018, for example, Walmart rolled out an earned wage access service, and more than 250,000 of their employees used the retailer's earned wage access application in just the first year. According to Walmart's senior benefits manager, they added that benefit to help workers to avoid expensive payday loans and late fees. And while I certainly think there are sufficient conversations, or very worthy conversations, I guess is maybe a better way to to put that, about what it is that workers make and how we support them and benefits. Certainly one of the ways that workers are seeking to solve the issue when they are in between pay periods, cannot make bills, have an unexpected life event, is to turn to things like high interest loans in order to make it by, or simply overdraft their bank accounts, having to make it through whatever life has thrown their way. There are different types of earned wage access programs. There are in-house programs where employers offer the earned wage access through existing payroll services and partnerships. Under these programs, the employer could fund the earned wage access services and has complete discretion over the amounts and frequency of employee paychecks. There are third-party vendor programs where employers or employees select a third party to provide earned wage access. Generally, third-party vendor programs reduce the employee's earned wage access amount from his or her net pay on the employer's scheduled payday. However, some third-party vendors have very little involvement with the employer, providing the service directly to employees and requiring the employee to repay the amount to the vendor on payday. While earned wage access pay may offer benefits to both employers and employees, there are consumer protections that I think we must consider and is the primary reason why I think Senate Bill 198 is so necessary at this point in time. In Nevada, we lead on consumer protection. One of our most sacred jobs as legislators is to protect Nevada consumers from unscrupulous and dangerous products and services. And we have a long history of thoughtful but balanced financial regulation in the state. And I believe that should continue with these applications as well. That is why I've introduced Senate Bill 198. This legislation leads the nation in regulating a new promising market alternative that has the power to bring much needed relief to hardworking Nevadans. And particularly in this difficult time, as families are struggling, we need to find safe, secure means for Nevada families to avoid predatory credit products. Earned wage access is a new technology that enables employers to pay their employees as frequently as they need without disrupting their current payroll processes. However, with any industry, there are, of course, good actors and bad actors. So this legislation seeks to establish a full regulatory regime with built-in customer protections and requirements. Earned wage access can only be done if the employer is closely involved. That is the best way in which to ensure that consumers are not being taken advantage of. With the employer involved, it becomes a non-discriminatory benefit, just like any other employee benefit, and there's no individual underwriting, and this service shouldn't be based on income level, skin color, gender, or any other demographics. Employer involvement is critical to verify and seamlessly provide the earned wages. And so without the employer, you can see that there would be no wages. Without the employer, you also can't verify what wages have been earned and what payments are a loan against future wages. Critically, without the employer, you may be forced to debit consumer bank accounts, which often results in causing overdrafts when we are supposed to be preventing them. Without the employer involved, there is a strong possibility that this becomes just internet payday lending by another name. Nevada must act now, and so failure to pass Senate Bill 198 can expose hardworking Nevadans to potential bad actors of this industry. Some companies that are not integrated with employers still put themselves forth as being involved as an employer integrated system and can take advantage of unsuspecting customers who may rack up incidental overdraft fees, who may be tricked with deceptive business practices like calling loans gifts, or by asking them to pay additional interest in the form of tips or by GPS tracking individuals. This legislation is intended to ensure that there are sufficient protections to guard against some of these predatory practices. This legislation requires licensure, consumer protection, transparency, employer verification, and more. It prevents general solicitation of the public so that the service can be offered in a way that is secure and trusted by the employer and employee alike. Madam Vice Chair, I would like to go through the sections of the bill. I would also note that we did provide a conceptual amendment that is still very much in a working process with some of the other stakeholders involved, including legal aid and the FID, to ensure that we can get the policy on this right. So I will talk about the sections of the bill and then discuss briefly some of the points in the conceptual amendment so that the committee is aware of not only what the bill is seeking to do, but also where we are in terms of negotiations. Section 12 requires a person who wishes to provide earned wage access services as an employer integrated earned wage access provider to obtain a license from the Commissioner of Financial Institutions, which will expire annually. The Commissioner is required to adopt regulations establishing the fees for issuing and renewing a license. Sections 12 and 13 also require the Commissioner to develop an application for licensing as an employer integrated earned wage access provider containing certain information, including but not limited to an applicant's financial statements for the immediately preceding year, which must have been audited by an independent certified public accountant, a copy of the proposed terms and conditions of use, which will govern the provisions of earned wage access services, a copy of the policy concerning the privacy of a user's information, the schedule of fees proposed to be charged to a user or employer, a statement from the applicant relating to a possible child support court order, and any information required by regulation which may be adopted by the Commissioner pursuant to Section 19 of the bill. Section 15 requires an employer integrated earned wage access provider to submit a report to the Commissioner on or before June 30th of each year. The report must contain financial statements of the immediately preceding year that have been audited by an independent certified public accountant, and a copy of each complaint that has been filed against the provider with the Better Business Bureau or the Consumer Financial Protection Bureau, and a description of the resolution, if any, for each complaint. Section 16 requires an employer integrated earned wage access provider to develop and implement policies and procedures to respond to questions and complaints from a user. Before entering into an agreement with the user, inform the user of his or her rights under the agreement, and fully and clearly disclose all fees associated with the earned wage access services, and allow the user to cancel at any time without incurring a fee and comply with all local, state, and federal privacy and information security laws. Section 17 provides that if an employer integrated earned wage access provider is unable to be repaid the amount of money delivered to a user, absent fraud from the user, the provider is prohibited from collecting or attempting to collect that money from the user, or reporting any information regarding the inability of the provider to be repaid to a consumer reporting. Section 18 also prohibits an employer integrated earned wage access provider from sharing with an employer any fees that were received from or charged to a user, or paying any other compensation to an employer that is directly related to any fees received from or charged to a user. Finally, sections 20 through 22 set forth that providing earned wage access services by an employer integrated earned wage access provider shall not be deemed a loan, and laws governing a person engaged in the business of transmitting money do not apply to employer integrated earned wage access providers. However, earned wage access services provided by a third-party earned wage access provider are deemed a loan and are subject to the laws governing high interest loans and instruments. With respect to the conceptual amendment, which is available on Nellis for members of the committee and also for the public, the bill as amended will include at a minimum some of the following consumer protections. We're looking for limitations on what providers can call fraud, raising it to intentional and willful fraud, providing limitations on debiting authority, providing requirements for a new mechanism for FID to provide input regarding additional future rules and regulations should they be warranted, provisions that strengthen FID's examination, supervision, and licensure authorities, a surety bond requirement, a requirement for retention of books and records, a requirement to notify in a timely manner FID of any changes to corporate address, name, or DBA, commonly known as doing business as, a provision that the license is non-transferable, date changes to conform with FID's licensing schedule, access to books and records in state, reimbursement for the costs of any supervision, audit, examination, investigation, or hearing conducted out of state, all fees and assessments, application, initial licensure, renewal license, examination, CPA and attorney general fees, and disciplinary action, including license suspension rights. We are, as I mentioned, still in the process of working with the Financial Institutions Division and also with legal aid to work on these amendments and some additional changes that may be. We look forward to coming to a resolution that will both provide the highest protections for consumers, while also ensuring that they have access to this new important form. Madam Vice Chair, this does conclude my remarks. I would urge your support of Senate Bill 198. I also have with me today who is available to answer questions alongside myself, Matthew Kopko, and also Alyssa Nave. And we would stand ready to answer any questions that you, Madam Vice Chair, or the members of the committee may have. Thank you.
Okay, thank you for that. Senator Pickard.
Thank you, Madam Vice Chair, and thank you, Senator, for bringing this bill. I was actually unaware of this as an offering until I first encountered the bill, and your lobbying team called and we talked about it, and I thought that was very helpful. I appreciate you having that done in advance. I just have a couple of questions because this is creating a new licensee requirement, a new license, as I understand it. And what happens if employers are doing this on their own? I'm a little unclear if they are required to be licensed to do this if they're going to offer this as an in-house operation.
Thank you, Senator Pickard, for the question. And I think a great question, definitely, with respect to the in-house. And what we are trying to do is ensure that anywhere where they are offering this, there would need to be a license so they would conform with FID. Primarily, I think one of the safest ways and why we sort of focused on this in the language of the bill is having that employer integration with the companies, because that's how you can actually verify that there are in fact wages to be earned. You can verify that that employee actually, works at that company, and you have all of those checks and balances. So you're not providing some sort of advance on what they may be getting for pay, but rather you're integrating with that employer. So for any employer that would have something that would be more in-house, depending on how they set that up, they may fall within this. But primarily, I think the common way that even with an in-house agreement is usually through a particular vendor, and then they set that up with the employer. That vendor would need to be licensed.
Right, and that makes all the sense in the world. I would expect that if someone's coming in and connecting to or linking up with a employer's payroll system, and then offering that through their own, not the employer's systems, but offering that through their own, that they would have to have a license. My thought is, because my understanding was that the Walmarts and Targets of the world, they've actually brought this into their payroll systems, so they are offering payment on the go as opposed to accruing wages that then are paid at the end of the period. But many of the smaller outfits, because obviously Walmart and Target and the national chains, they're going to have the wherewithal to do this probably completely in-house, or at least with a closely linked vendor. My thought is, as we get into the smaller operations, so for example, my law firm, we have 11 people working for us, and so maybe we wanted to do this. Well, we don't even have internal payroll operations. We contract with a provider to do the manual, the issuance of those paychecks. And so I would have to go to someone outside to do that. If I were then to say, okay, I'm going to do this on an internal basis, am I going to be required to be licensed, or would it be the paychecks that would do it? Or what happens if they're already licensed through FID? Say I'm going through my bank and they offer this. Do they then have to get a second license? I'm just trying to figure out who the licensees are.
Yes, and thank you, Senator Pickard, for the question. And I think there's a bit of confusion around this. Most employers, if you were going to set up a different structure for payroll, let's say you wanted to pay your employees on a weekly basis. Most employers don't, right? Most employers do either on the 15th, 30th, or they'll do a 2-week pay period. And I think most of us are familiar with that as a form of pay. If you were an employer who wanted to do a weekly pay service, or even something more frequent than that, that falls more within the agreement that you would have with your own payroll company than it would with this particular type of service. And so that really falls, I think, outside of the bounds of when we say in-house. in-house applications or in-house services that might be provided. At that point, you're really just in the space of this is what your payroll service contract looks like with your payroll company, and potentially, you work that out with them. When, for instance, Target is a great example, and I'll let Matt, Mr. Kopko, jump in if he has anything to add as well. But when other corporations we're talking about the in-house, we're really talking about these employer integrated systems where we are seeking to license them to ensure that we can protect the consumer, that we're not inadvertently sharing personal information that shouldn't be shared. And that's what this bill is seeking to do. But that's where there's employer integration, such that the employer is working directly with the vendor. So it's not employee to vendor, it's employer to vendor. So if you were going to set this up as an employer, you're either talking about something that changes the way in which you do payroll generally, or you're talking about one of these employer integrated systems. And that's what we're seeking to license. Most employers are not going to set up their own system to work with the paycheck company to then, or with the payroll company to try to pay their employees a little earlier. It becomes very costly, and I think then starts to just delve into a different form of payroll. But these in-house services are really more the vendor contracting directly with the employer. That's what we're seeking to get at. And I don't know if Mr. Kopko, you had anything else you wanted to add on that to help clarify.
Thank you, Chair Spearman and members of the committee. My name is Matthew Kopko on behalf of Daily Pay. To you, Chair Spearman, and through you to Senator Pickard. Yes, Majority Leader Cannizzaro is correct. Most leading employer-based vendors work with not just employers large and small, but also PEOs, payroll firms, and other financial infrastructure firms regarding payroll. I believe your question relates to if you were interested in building your own on-demand pay system from scratch in-house, fully in-house, i.e. without the use of a third-party vendor. Again, most employers do this through a vendor. For example, some of the companies that were mentioned work with our company and some of our competitors. But if you were to do this entirely in-house, the regime under the bill from my read of it would not apply to you. Again, this is for employer integrated on-demand pay providers, i.e. the provider of the on-demand pay service. An employer trying to provide a similar service or running payroll more frequently in-house, just as the Majority Leader stated, would have to follow their own existing compliance procedures, just as if they wanted to run payroll daily or run payroll more frequently. And again, the overhead and compliance of that is part of why they don't do it, and part of why the market is moving towards these vendor-based relationships.
Right, and I think you're almost there in terms of my question, because what I'm trying to do is find the intersection. Where does this apply and where does it not apply? Because as I read this, I thought if I were, and I maybe using my own firm was a bad example, because yeah, with 11 people, it's too expensive to try to do a payroll run every day. But I'm thinking, say you get into the 100 to 500 employees. So we're talking about a significant operation where your economies of scale may come into play. At what point is a license required? Because they're probably not, they may still be working with a payroll provider, and maybe that payroll provider will set up a pay structure, a cost structure, so that it makes it so that the employer can actually offer the on-demand type payment or the frequent payment. Because as I look at this in the language of the bill, it's couched in terms of how frequently it's paid, not in terms of well, I shouldn't say not in terms of the vendor, because it also implies that there's a vendor involved. So what I'm trying to do is tease out, where is the line where the bill applies, and where does the line or where can they stop and not have the bill apply? Does that make sense? I'm probably not being very clear.
Yes. Thank you, Chair Neal, and to Chair Neal, and through you to Senator Pickard. Yes, no, your question makes sense. The regime requires the licensure of the provider, again, the service provider that would be actually facilitating the on-demand pay service. Employers would not have to register under this bill. And again, medium-sized providers are offering this service typically through a PEO, and firms like ours and others actually tend to, again, not just work with agreements with employers, but work with leading payroll providers, PEOs, and others like that, so that through a channel distribution, the service can be offered through a technology integration through the PEO. And in that case, again, for example, in no case would the employer be required to be providing, because it's not an employer integrated on-demand pay provider. That's just an employer, which is also defined in the bill. So licensure would be limited to the actual provider of on-demand pay services.
All right. Thank you. I appreciate that. And then just, if I may, Madam Chair, I know I've taken a lot of time, just one more question. With respect to Section 17, if an employer integrated on-demand pay provider provides on-demand and is unable to be repaid, that tripped me up, because in my view, we're talking about a payroll, a more frequent payroll processing as opposed to a loan, because when we're talking about employment in 20, we're talking about employer integrated on-demand payment providers are not considered loans. But then when we go to the third party, it is a loan. And so I'm trying to figure out how would a repayment be required in any instance when we're talking about a payroll.
Thank you, Senator Pickard, for the question, and a great one, and I think an important point of distinction, and that has to do with instances where maybe there was a discrepancy, and I'll say briefly the intent, and then I'll turn it over to Mr. Kopko, because I think he can walk through that a little bit more detail. The intent here is to ensure that the consumer, the employee, is not being charged if there was some sort of discrepancy along the way, that there's nothing for them to pay back. We're trying to ensure very strictly here, because there are actors where they may be, giving what amounts to a loan or a paycheck advance or something like that would have to be repaid, and we're trying to ensure that that is not what this is at all whatsoever. So if there were a discrepancy, they would not have to pay that back, so that there isn't a loan. If Mr. Kopko has anything he would like to add to that.
Thank you, Senator Cannizzaro, and to you, Chair Neal, and through you to Senator Pickard. Yes, again, the majority leader is right. Section 17 is really intended to be one of the key consumer protections actually in the bill, which points out that to the extent an employer is either delinquent or is unable to make payroll, the provider cannot look to the employee for recourse. So this is, essentially what's considered a non-recourse section to protect consumers, because as you can imagine, from time to time, employers in bad economic circumstances do not make payroll, or otherwise in normal course can pay delayed payroll. And this is a clear protection so that the provider is not looking to the employee for repayment. Its arrangement is with the employer as the facilitator of the on-demand pay services, and any discrepancies in payroll should be resolved with the employer.
All right, so to make sure I'm clear, this isn't talking about repayment of a loan, but repayment if there's a discrepancy in the payroll processing where the employee is presumably overpaid, even though the employee may have filled out his time card correctly or whatever. It's not the fault of the employee. That's going to be between the third party provider and the employer to resolve. But I'm assuming if the employee is overpaid, if he was paid more than he earned, that would then at most be offset against future income, so that we're not paying an employee who didn't earn the wage. That would come out of future earnings. Is that a fair statement?
Thank you, Senator Pickard. To you, Chair Neal, through you to Senator Pickard. That's correct. In normal course of payroll, as you can imagine, from time to time, even employers have discrepancies or errors in the payment of payroll. So that's one use case example. The typical example, though, that was drafted for this section is really more about a missed or late payroll to really enshrine the concept that providers should not be looking to the employees for repayment. And again, in normal course, employers have mechanisms for resolution of errors in the processing of payroll. And again, the on-demand pay provider actually serves as another consumer protection in this space, because now you have a third party who is working to resolve any discrepancy, as opposed to having to have employees out money or on the hook having to petition their employer for any sort of payroll related issue.
All right, thank you. I appreciate your answers, and thank you, Madam Vice Chair, for your indulgence.
Thank you for that. Senator Settlemeyer.
Thank you, Madam Chair. I appreciate the opportunity to ask a question. I'm also very grateful the gentleman from Daily Pay is here. So where in the bill does this limit it to only non-payback models? In doing some research on this, I'm still a little concerned here if we're going to allow payback models to access this potential licensure, or are we specifically limiting it within the bill, and if so, what section?
Thank you, Senator Settlemyre. To you, Chair Neal, and through you to Senator Settlemyre. The definition of employer integrated on-demand pay provider defines the service as a provider who uses an employer integration to verify earned income. And the bill is framed such that only employer integrated on-demand pay providers, i.e. those who do not engage in that debiting activity or the third-party repayment, would be licensed under this section. So it requires fundamentally in the definition an integration with the employer, not just contractually, but through payroll and through data.
Okay. Well, to me, we might want to make that a little more clear that this follows the Consumer Financial Protection Bureau's concepts and that this is only applying to non-payback models. Otherwise, as I'm seeing online, this could get us into all types of problems. So I'm just saying we might want to make that a little bit more clear. Otherwise, we get into this discussion of credit and payback. Thank you.
Okay, thank you for that. Members, any other questions? So I just have one quick question because we haven't talked about interest. Would there be interest that's accrued on this? I guess, I don't know what you would call it. You call it an on-demand payment, but is there interest?
Chair Neal, to you and through you, I guess is how we say it in this section. The bill requires full fee transparency. And again, because the service is not credit and is really the facilitation of real-time payment, there are no interest charges, there are no loans, there are no rollover fees, and there are no other hallmarks of credit involved. But there's a requirement of transparency for all fees, of course. But they're fees for the service as opposed to an interest, which would be more of a concept in a credit construct.
Okay, thank you for that. Senator Lang.
Yeah, so as an operations manager for a small business, I can really see the benefits to this because I did payroll for 2 businesses and I always had my employees coming to me and asking me for advances on their paychecks because maybe for that month rent was due before they could get their paycheck and such. And to me, having another person that could do this instead of having to cut the check, figure out the taxes and all that would be really helpful. Can you remind me how much the fee is?
Thank you, Senator Lang. To you, Chair Neal, and through you to Senator Lang. Our typical pricing structure is $1.99 for the legacy transmission, which is called ACH, which typically takes 8 to 24 hours for the funds to arrive in the employee bank account. And then there's a $2.99 option, which is our typical pricing for instant delivery, which is typically within about 20 minutes or shortly thereafter. Other providers have different models. There are some versions that if you use a certain type of pay card or other type of system with the provider, that the fees can be less, including up to free in certain circumstances. And in all cases, payroll, full remainder payroll on payday, whether or not you use the transaction for the service, does not have any charge associated with it. So
you could use like a net spend card or something and have the money put on there?
Yes, employees can direct funds to any destination account of their choosing. And again, it's an entirely voluntary, non-discriminatory benefit. So to the extent it is not used in a given pay period, there is no charge to the employee. And again, in all cases, full net remainder pay never has any charge associated with it.
And there's no charge to the employer, right?
We offer employers the ability to subsidize. Some do. That typically takes the form of, for example, 1 free additional transaction per pay period. And we continue to see kind of shifts in the market where that's becoming more and more common, but it's part of structuring the system. And so we offer a subsidization option and the employees or the employers, depending on the preference of the system.
Okay, thank you.
Okay, thank you for that. Senator Settlemyre. I see your hand was back.
Yeah,
okay.
Yeah, we're arguing about who gets to unmute the button. Sometimes I'm not quick enough and you're much faster than I am. That last couple of questions kind of brought it up. So, and I know I'm only talking for this one gentleman's company, but what size does this really work? I mean, if I have 3 employees and I don't pay that much, in wages, or what's the traditional, do you guys have a cutoff point that if you don't do this much in payroll a month, we don't, deal with it? or does, is this just, I don't know, some of this looks like it's almost like it's a payday loan lender in some respects. So that's where I'm getting a little bit confused. But what's the standard, what's the cutoff point that you don't deal with a small business? Because I assume there has to be a certain point you're like, you guys don't do enough quarterly to qualify.
Yes, thank you, Senator Settlemyre, and to you, Chair Spear, through you to Senator Settlemyre. We do work with employers large and small. I would say our standard employer is 1,000 or more employees, but we do have a small and medium-sized business sales division. And again, the exciting thing about this industry is that as it matures, we're able to build all types of APIs to work with all of the payroll providers in the industry, all of the PEOs in the industry. And so we are in circumstances oftentimes where this is kind of a check the box add-on service for a small or medium-sized employer who's working with XYZ PEO. And so long as we're able to write an API and technology that works with the PEO, they can distribute that as a voluntary offering again to any of their clients. So it is becoming increasingly available to smaller and smaller business types as the industry matures and grows.
Okay, I really didn't necessarily get into the question of, what's your industry or your business's cutoff point, like if you do less than $10,000, a month in payroll, does that, create the limitation, or do you have any? I mean, do you work with guys that are as small as, $5,000, or do you, I was just asking specifically your particular business, if there's a point that it's not economical to enter in agreements with.
Thank you, Senator, and to Chairman Spear and through Chairman Neal to you.
Just go direct.
Apologies. Yeah, so typically the enterprise sales force is focused on medium and large size businesses, typically 1,000 or more employees. But again, the exciting opportunity for the small, medium sized part of the business here is that once you create an integration with XYZ PEO provider, then all of those providers' clients can use them. So we used to have to build custom technology for every new client for our first few dozen clients, but now we know that, you use ADP for payroll and you use XYZ time management system. We have an off the rack integration already built now for that, given all the integrations we've seen. So it is becoming increasingly available to smaller and smaller employers.
All right, I guess I'm just being dense because I don't hear an answer there necessarily what, for $5,000 person, but I'll get that. One last question, because it was brought up about these consumer transaction fees, which, basically are mandatory if you want to participate. So in reading this other article online, though, doesn't that then get into the concept of credit under Regulation Z of what's called TILA? And again, I'm just trying to learn all this as I go along.
Thank you, Senator. So as you may have seen, I believe it might have been you who previously referenced the CFPB guidance on this matter. Fundamentally, the analysis of whether or not this is credit does hinge on that payback versus non-payback model, as you mentioned. And so typically when something is credit, fees, of course, are interest. When something is not credit, those fees are not interest. They may be service fees, transaction fees, technology fees, or something else. As you may have seen from that CFPB advisory opinion, there is a broader framework for evaluating earned wage access providers. It's a narrow provision that alludes to either no fee models or nominal processing fee models. But the reasoning and the analysis in that opinion points out why most employer-based services are involved in a construct that is not credit in nature, because again, going back to the discussion regarding Section 17, there is not a looking to the employee for repayment. It is more like the facilitation of real-time payroll.
Thank you for that. I'll just keep trying to learn. Thanks.
Hey, thank you, Senator Settlemyre. And I see Senator Pickard. So I want to say this because we do have a third bill. So we can take two short, quick questions. Being mindful, Majority Leader is working on an amendment to this bill. So we can have two more, and then I want to try to go to public testimony. So then we have time to hear the third bill, which has a little bit more people in the queue. So Senator Pickard and then Senator Lang.
Thank you, Madam Chair. Just wanted to follow up on a statement Mr. Kopko made, and I may have missed or misunderstood it. It sounded like there were roughly $4 to $5 charged on every transaction that you do on this, that were whether they be fees or captured under some rule. But it sounded like you were saying that there's $1.99 here, $2.99 there. that were captured on each transaction. So if we have 1,000 employees and you're doing a daily pay program, that's $5,000 a day that you're making on this, that you're taking from the payroll. Did I understand that correctly?
Thank you for your question, Senator. I apologize if I was unclear. It's an or there. It's $1.99 for the next day service, or it's $2.99 if you want the money immediately. Typical use patterns show employees use it about once a week. So, you know, our vision is the idea that employees can get paid as frequently as they want. So daily pay may be, you know, a bit of a mismoniker there, but the standard operation of the service is not a reliance on this daily. It's your typical interaction is about once a week from the employee.
But those are paid out of the paycheck.
Those are transaction fees assessed to the typically to the employee, or if the employer is subsidizing, to the employer. And again, if they do not access the service, there is no charge.
Perfect. Thank you.
Okay. Thank you for that. Senator Lang.
Thanks. Could you walk me through, okay, so I'm a small business. I have a payroll company. Let's just say I have paychecks. I have paychecks, and we're working with your company, and someone wants to access money, and they'll get that money out. You'll work through paychecks, if I'm understanding this correctly. But because we have paychecks, even though you're not charging a fee, they may charge us a fee for like putting this data in their system. Or
Sure.
do you have a contract with, I mean, I'm just asking if that's how it would work, or if under your contract, there wouldn't be any more fees.
Thank you for the question, Senator. So there are many integrations at play here. We integrate with a variety of leading payroll providers, including ones like those you mentioned and other large payroll providers. And then the other critical part of the system is not just payroll, but integration with the time management system and the accounting system, so that net take-home pay can actually be determined and calculated, which is, again, one of the benefits of the employer-based system, that you have the ability to actually limit this to net take-home pay. I would say the easiest way to think about this is a technology layer on top of all the existing processes. So adding an on-demand pay provider, at least under our construct, does not require you to change your arrangement with Paychex, or to get a new payroll provider, to get a new time and attendance provider. What we do is we contract with you, and then we have an integration with companies like Paychex, where we can facilitate, with obviously the employer and employee consent, that live data stream to calculate the net earnings balance. And then it sits on top of that procedure so that the employees receive their on-demand pay as requested, and through the employer integration, it's automatically resolved on payday. So there's no employee account debiting or direct-to-consumer activity.
Great, thank you. That clarifies that for me.
Okay, thank you for that. So we will go ahead and move to callers who are in support of SB 198.
Thank you, Vice Chair. To testify in support of SB 198, please press *9 now to take your place in the queue. Again, to testify in support of SB 198, please press *9 now to take your place in the queue. Excuse me. Vice Chair, you have no callers in support at this time.
Okay, so we will move to who is in opposition of SB 198.
To testify in opposition of SB 198, please press *9 now to take your place in the queue. Caller with the last 3 digits of 301, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Thank you, Chairwoman Spear, Vice Chairwoman Loop, and members of the committee for allowing me to testify today. My name is Sangeeta Raghunathan, and I'm the General Counsel and Chief Compliance Officer for EARN. I also want to thank the Majority Leader, Canizaro, for her leadership on this important issue and taking the time to understand the intricacies of the on-demand pay industry. EARN is a fintech company with a direct-to-consumer on-demand pay product called Cash Out. EARN has over 18,000 customers in Nevada and over 1.3 million nationally. Our Cash Out product is an alternative to expensive payday loans, overdraft fees, and the late bill fees that cause a cycle of debt. EarnIn is asking that SB 198 is strengthened to treat on-demand pay providers equally and to include strong consumer protection provisions like fee caps, debit attempt limits, and annual usage reporting requirements to FID, including transparency around how earnings are verified. Legislation should not be used as a tactic to pick winners and losers in an industry. We ask that Nevada treat all on-demand pay providers and consumers equally. 67% of our customers, many of whom are small business employees, government workers, and teachers, see fewer overdrafts when they start using cash out, and 66% are able to pay their bills on time or easily using our direct-to-consumer on-demand pay product. EarnIn is not a lender, and our cash out product is not a loan. We only give people access to the amount of money that they have already earned. People support EarnIn voluntarily with tips. Our business model provides a no-cost, no interest, no fee option for workers to access their money when they need it and at a level that meets their budget. While SB 198 is well-intentioned, it currently leaves out on half of the on-demand pay industry and its consumers by excluding the direct-to-consumer model from being treated equally. In fact, the bill would consider direct-to-consumer providers to be alone, even though the employer-integrated and direct-to-consumer providers offer essentially the same service. We believe that any bill that regulates on-demand pay providers should encompass the entire industry. The similarities between employer-integrated and direct-to-consumer providers are we both give people access only up to what they have already earned. We are both non-recourse. We both provide workers access to third-party funds based on the workers' accrued earnings, regardless of whether the service is employer-integrated. The money advanced is never directly from the employer's payroll. Both B2B and B2C providers have authorization to debit the consumer's account for repayment. The only differences are employer-integrated providers sign contracts with employers while we have agreements directly with workers. We give workers the flexibility to take this tool with them no matter where they work, whether they're employed by a big corporation or at the coffee shop down the street. Employer-integrated providers verify employee wages with the employer, whereas we verify wage information, such as timesheets and wage stubs, with the employee's explicit permission. Employer-integrated providers charge employers and customers for this service in the form of transaction fees. We accept voluntary tips from workers directly if they choose, but we always provide any worker the option to access their pay at entirely no cost. This includes no transaction fees. Similar bills have been proposed in New Jersey, New York, Georgia, and South Carolina, and they have not passed because of the unintended consequences of acknowledging only half the on-demand pay industry and lacking the basic consumer protection element. We would really welcome the opportunity to speak with the Senate Majority Leader, committee members, and all stakeholders on this issue so that we can ensure consumers, especially those employed by small businesses, are protected and provided with options to access their earnings in real time. Thank you very much for the opportunity to speak.
Okay, thank you for that. Is anyone else in opposition?
We are currently in opposition of SB 198. To testify in opposition, please press *9 now to take your place in the queue. Vice Chair, you have no more callers in opposition at this time.
Okay, so we will move to neutral.
To testify neutral on SB 198, please press *9 now to take your place in the queue. Caller with the last 3 digits of 193, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning. For the record, my name is Peter Aldous, Peteraldous. I'm a staff attorney at Legal Aid Center of Southern Nevada, where I help low-income Nevadans protect themselves from predatory lenders. I'd like to thank Madam Vice Chair and members of the committee for this opportunity to comment this morning. I'd also like to thank Majority Leader Canizaro for bringing this legislation, as it is important for the state to regulate this new and potentially helpful service. I appreciate the continuing dialogue we've had regarding this bill. For the most part, I believe this bill will help low-income Nevadans by giving them a safer and less expensive option to meet unexpected expenses. I especially appreciate that the bill makes a distinction between employer-integrated and direct-to-consumer providers, since the relative risk to consumers is much lower in the employer-integrated model. I still have a few concerns with the bill that I hope can be addressed. I want to be sure that the Financial Institutions Division is able to effectively regulate providers, and I echo the concerns that they've raised previously. I am also concerned about language in Section 17 regarding recourse in cases where the provider believes that fraud has occurred. Unfortunately, financial institutions make mistakes, and I want to ensure that the burden for resolving providers' mistakes is borne by the provider rather than the users who are already in financial distress. Again, I appreciate the dialogue we've had with the sponsors of this bill, and I look forward to continuing that conversation. Thank you again for this opportunity to comment.
Okay, thank you for that. BPS, is anyone else in neutral?
Yes, Vice Chair, please stand by. Caller with the last 3 digits of 306, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning. This is Commissioner Sandy O'Loughlin. SID. That's SANDYOLAUGHLIN. The Financial Institutions Division is currently working with stakeholders to establish stronger consumer protections to make this bill work for all. I thank you for the opportunity.
Okay, thank you for that. BPS, is there anyone else in the line?
Vice Chair, you have no more callers neutral at this time.
Okay, thank you for that. So any closing comments, Majority Leader?
Thank you, Madam Vice Chair. I just wanted to again thank the committee for allowing me to be here to present Senate Bill 198. I think it's so important for us to take the step in being able to regulate this in a way that will ensure consumer protection, because this practice is going on regardless of whether we step in or not. And so I think it is incumbent for us to really take the initiative in ensuring that what we put in place makes sense, because employees are accessing this, they are utilizing it. And if we can ensure there's consumer protections built in, then that's what we should be doing. So again, thank you for all of your time. Thank you for all of your questions. And it's always good to be here in Commerce and Labor.
Okay, thank you for that. So we will go ahead and close the hearing on SB 198 and then open the hearing on SB 229.
Thank you, Madam Vice Chair. Are you inviting me to the dais?
I am.
Great. Well, hello, everybody. My name is Senator Julia Ratty, and I represent Senate District 13, which is kind of the middle of Reno and Sparks. I'm thrilled to be here today with you in the Senate Committee on Commerce and Labor, my first visit with you here this session. I am very excited to that talks about the role of a very important part of our healthcare workforce, and that is pharmacists. I'm saying these words very seriously. If there's a silver lining to the pandemic, and I say those words with caution, knowing that we have many families who've lost loved ones, and I do not want to in any way understate what has happened there. But if there's a silver lining, it is that the pandemic has exposed some weaknesses in our system of care. And we've certainly seen that in terms of the disproportionate impact on people of color and other communities. We've seen that with the lack of public health infrastructure. And in this case, we have seen it in a practice that we have in state law, which is something that's known as a collaborative agreement. That allows us to get the maximum benefit out of the workforce that is pharmacists. And that when push came to shove and the pandemic hit and we were in a dire need to deploy that workforce, that the way that the collaborative practice language was set up in statute did not allow for that to happen. And instead, we had to have some emergency orders to allow pharmacists basically to work within their scope, to work at a level that they've already been educated to work at a level that the state law had acknowledged they could work at, but there were just some technical barriers in the law that prevented it from happening. So this bill comes forward, and again, I want to be very clear here, collaborative practice agreements between pharmacists and physicians are already in the state law, but this bill comes forward to try to remove some of the technical barriers that made it impossible for us to use that workforce in a way that was completely appropriate within their scope of work, during a pandemic. And why it's important is that once the emergency orders are lifted, we still have a huge access to care issue in the state of Nevada. I want to express my thanks to the Nevada Pharmacy Alliance and the Nevada Society of Health System Pharmacists who put together a quick 2-page graphic for you. It's in the exhibits if you like to see bullets rather than a white paper. And we are still 45th in the nation when it comes to access to healthcare. We know that as the state of Nevada, we have many, many areas of our state that are healthcare shortage areas where there just aren't enough practitioners. We are 48th in the nation in terms of primary care physicians per 100,000 population. Yet at the same time, 90% of Nevadans live within 5 miles of a community pharmacy. Pharmacies and pharmacists, by their nature, are neighborhood-based. They are perhaps some of our most accessible healthcare providers. And we are underutilizing them. Again, they have a doctorate level education, they have a well-defined scope of practice, and collaborative agreements that allow them to work with a physician. So let me just try to give you an example. Let's say I come down with the symptoms for strep throat. And I have a primary care provider. I'm lucky enough to have a primary care provider, but it's going to take several days for me to get into that person. And if I go to my pharmacy, if my pharmacist can run a test, read that test, and give me the prescription for strep throat, and in this specific example, lots of research, we know what drug to prescribe. We know that drug is not particularly dangerous. We know that if we get it to you more quickly, that you're likely to have a much better outcome. If all of that can happen, if I drive 1 mile from my house to my local grocery store that has a pharmacy situated in it, I'm going to have a significantly better health outcome. It's going to be significantly more convenient for me. And my employer is probably going to see me back at work more quickly. The downstream effects are significant. That's what we're looking to happen here. And the way it happens is that that pharmacist has an agreement with a physician, and they've already agreed within the pharmacist scope of practice what that pharmacist can do and how they can do it and under what strict protocols they can do it so that the safety of the patient is still maintained, that patient gets access to healthcare. We haven't broken the provider relationship, but we are utilizing a professional who has the skills to help us get what we need in a convenient, cost-effective location. That's the general idea. So basically what this bill does is it removes a couple of barriers. First, it removes the language that says that these collaborative agreements can only take place in a medical facility. You can tell by my example that my grocery store with that pharmacy counter in it is not a medical facility. So our law would prohibit the example that I just gave you from happening. It also takes away the requirement that there has to be a referral. So if I have to go to my doctor and that doctor has to refer me to that pharmacist, it really takes away the whole example again, right? Not helpful if for something as simple as this strep throat situation. It takes out another limitation that says that the doctor-pharmacist relationship has to be within 100 miles of each other. If we've learned anything in the pandemic, it doesn't matter how far we are away from each other, that we can still maintain a significant relationship. And there's no reason, no logical reason why that doctor and that pharmacist need to be within 100 miles of each other. And it takes away what was written into the law at one point, which was a piece that says that pharmacist has to tell that patient that they're not a doctor, that patient is consenting to this happening through a pharmacist. We think it's unnecessary. We're open to conversation on that piece. It just doesn't, it seems obvious, and it's more paperwork that needs to be generated every time there's a visit. And then it does clear up the definitions of what needs to be in the agreement between the doctor and the pharmacist so that everybody's on the same page. They know what the pharmacist is allowed to do and under what conditions and under what rules and protocols. So that's basically what the bill does. I have a team of people here to help present the bill and answer your questions. So I'm going to turn it over to Beth Slamowitz, who's our Senior Policy Advisor at the Department of Health and Human Services on pharmacy. And she's going to walk you specifically through the components of the bill, unless, Chair, given the time, you would rather just go straight to questions. So to the preference of the committee, do you want a bill walkthrough or would you like to just go to questions?
I want a quick bill walkthrough because I think it's super important to hear the pharmacy perspective, because I know my questions come from.
Okay. We'll let Dr. Slamowitz walk through the bill then. Dr. Slamowitz?
Thank you, Senator Ratty, and thank you, Vice Chair Neal, and members of the committee. For the record, my name is Beth Slamowitz, and I'm a Senior Policy Advisor on Pharmacy for the Department of Health and Human Services. So I just want to kind of give a brief introduction to what a collaborative practice agreement is for those that are unfamiliar, and then walk through the sections of the bill and what language has been changed with the bill. A collaborative practice agreement creates a formal practice relationship between a pharmacist and a healthcare practitioner, whereby the pharmacist assumes responsibility for specific care functions. The extent of the services under that agreement depends on state statutory regulatory provisions for that authority, as well as terms of the specific agreement between the pharmacist and the healthcare practitioner. In 2015, the National Governors Association presented the following state policy considerations in regards to collaborative practice agreements. They stated that states should enact broad collaborative practice provisions that allow for specific provider functions to be determined at the provider level, rather than set in statute or through regulation. They also stated that states should evaluate practice setting and drug therapy restrictions to determine whether pharmacists and providers face disincentives that unnecessarily discourage collaborative practice agreements. Healthcare workforce is a critical component for a healthy Nevada. The intent of SB 229 is to remove current collaborative practice authority barriers that exist and increase the flexibility by defining elements that are more appropriately determined by the parties at the practice level who voluntarily enter into a collaborative practice agreement. It is in the interest of the state to encourage the use of these arrangements between pharmacists and practitioners to expand and provide access to care. With that, I'll move into each section of the bill and describe what has changed and what has remained the same. In section 1, NRS 639-0124 is amended to remove the requirement that the development of written guidelines and protocols in collaboration with a practitioner are intended for a patient in a licensed medical facility or in a setting that is affiliated with a medical facility where a patient is receiving care. A pharmacist's practice setting or a patient's relationship with a medical facility should not be a barrier to the pharmacist and practitioner's ability to enter into an agreement. In section 2, subsection 2, the language removes the barriers for a practitioner to enter into a collaborative practice agreement, which include the requirement for a patient referral by a practitioner to a pharmacist, the requirement for the practitioner to obtain an informed consent from the patient who is referred, and the requirement that the practitioner practice his or her profession within 100 miles of the primary location where the collaborating pharmacist practices in the state. Pharmacists and practitioners may specify the level of patient involvement within the collaborative agreement, depending on the level of service. Elements such as informed consent, written consent, or opt-out provisions may be appropriate as determined by the parties within the agreement. Section 2, subsection 3 adds language that a collaborative practice agreement does not grant a pharmacist the authority to engage in an activity that is outside the scope of practice of the collaborating practitioner. Section 2, subsection 4 maintains the current language that outlines the requirements of a pharmacist who engages in the agreement. These requirements include documentation of the treatment of care, documentation of any decision or action concerning the management of drug therapy, the maintenance of records concerning the care or treatment for at least 7 years, the requirement to comply with all provisions of HIPAA, the requirement to provide a patient with written notification of any test that was administered and the results, any drug or prescription filled and dispensed, and the contact information of the pharmacist. Language removed again intends to remove the barriers of elements that may be determined at the practitioner level through the individual agreements. Language removed includes the requirement for a pharmacist to obtain informed written consent of a patient, which must include a statement that the pharmacist may initiate, modify, or discontinue the medication of a patient, is not a physician, osteopathic physician, advanced practice registered nurse, or physician assistant, and may not diagnose. Lastly, the requirement that a practitioner may not enter into collaborative practice agreement with a pharmacist for the management of a controlled substance is removed. It is recommended that all prescription drugs, including controlled substances, may be included within a pharmacist's collaborative practice authority. Section 3 refers to NRS 6392627. The language in Section 3, subsection 1A through J, is maintained and defines what must be included in a collaborative practice agreement as the following: a description of the type of decisions concerning the management of the drug therapy that the pharmacist is authorized to make, a detailed explanation of the procedures that a pharmacist must follow, including documentation and requirement to report to the practitioner and receive feedback, procedure by which a pharmacist will notify the practitioner of an adverse event, procedure by which a practitioner will provide the pharmacist with a diagnosis and any other medical information necessary, a description of the means by which the practitioner will monitor clinical outcomes and intercede when necessary, authorization for the practitioner to override the agreement, an authorization for either party to terminate the agreement, the effective date of the agreement, and the date by which a review must be conducted for the renewal of the agreement. Subsection 1K is removed, which requires the inclusion in the agreement of the process by which the pharmacist will obtain informed written consent. Section 4 is amended by removing subsection 1A through C and replacing it with language which defines what must be included within the written guidelines and protocols developed by a pharmacist in collaboration with a practitioner, and which authorizes collaborative drug therapy management. Language that was removed includes the provision for collaborative drug therapy management for a patient receiving care in a licensed medical facility. If developed to ensure continuity of care for a patient in a setting affiliated with a medical facility, requirement for a pharmacist initiating or modifying drug therapy in a setting mentioned to provide written notice within 72 hours to a practitioner or enter into an electronic patient record system shared by the pharmacist and practitioner. Requirement to state the conditions under which a prescription may be changed by a pharmacist without a subsequent prescription from that practitioner. The amended language requires the following to be included without limitation within the written guidelines and protocols: a description of the types of decisions that a pharmacist can make regarding the management of drug therapy. This includes, but is not limited to, description of diseases, drugs, or drug classes to be covered, the types of decisions a pharmacist can make regarding the diseases, drugs, or drug classes, the training the pharmacist is required to complete, the procedures the pharmacist is required to follow to make any changes to drug therapy or any other therapeutic decisions, including would be the criteria to make those decisions, and procedures for documenting or reporting to the practitioner, and procedures for the practitioner to provide feedback to the pharmacist. Subsection 2 requires that the Board of Pharmacy approve any modifications to the written guidelines established by subsection 1. Section 5 amends NRS 441A.110 to include a pharmacist within the definition of provider of healthcare within that chapter. In Section 6, it's amended and defines an agent as a pharmacist who cares for a patient of a prescribing practitioner, removing the language regarding, again, in a medical facility or in a setting that is affiliated with a medical facility. That concludes my overview of the sections of the bill. I'm sure there are plenty of questions, so I'll go ahead and stop there and let the questions ensue.
Thank you, Dr. Slamowitz. So before we open it up for questions, Vice Chair, with your discretion, I would like to let you know who's here and available to answer questions. So of course we have myself, we have Dr. Beth Slamowitz, who works for Department of Health and Human Services as the pharmacy advisor, but we also have Dr. Adam Porath, who is a pharmacist who works with Renown Medical and is practicing in the field. So for the more practical practicing in the field questions, he may be your best bet. We have Yen Long, who is here representing, and we have Liz McMenamin, who is here representing the retail pharmacists. So with that, we would be happy to answer questions.
Thank you for that. Senator Pickard.
Thank you, Madam Chair, and thank you, Senator Ratty. This is well outside my wheelhouse, so I just have a couple of basic questions that come from a legal perspective. Number one, I want to make sure I understand who we're talking about here, that we're talking about the ability with a particular pharmacist, not a pharmacy like CVS or, you know, I don't know, I go to Vaughn's, you know, we're not talking about the pharmacy, but an agreement between a pharmacist, a particular pharmacist, and a particular physician. Is that correct?
Dr. Slamowitz, do you want to take that one?
Certainly. So again, for the record, Beth Slamowitz, Senior Policy Advisor on Pharmacy for DHHS. So the way that a collaborative practice agreement works is the physician and the practicing pharmacist or pharmacists can be part of that collective agreement. So when you're mentioning a retail type of setting, collaborative practice agreements can take place in that setting where there are a number of pharmacists that are named and a physician that is working collaboratively with them. So, or with the pharmacy itself. It can work either way, whichever is defined within protocol. I know Yen Long is also on the line for the State Board of Pharmacy, and she may be able to speak to at least current statute and what that currently allows.
Ms. Long?
Thank you, Beth. Thank you for the question, Senator Pickard. So currently, the existing law does allow collaboration between one or more physicians and one or more pharmacists to collaborate and allow and authorize pharmacists to manage certain diseases or medications.
I'm sorry, Ms. Long, can you get a little closer to your microphone?
Yes, can you hear me now? Okay, Senator Pickard, I don't know if you heard my response, but current collaborative practice agreement does allow for one or more pharmacists and one or more physicians to collaborate together to determine what the pharmacists in the collaborative practice agreement are authorized to manage in terms of the patient care.
All right, I was just thinking in terms of, you know, the practical nature, you know, when we're talking about things like any long-term drug therapy, where particularly if there are reactions that need to be watched for, and pharmacies are busy operations, you know, every time I go to Vaughn's or CVS, they're scrambling to get everybody helped. And so since we're now adding diagnosis and treatment, I just wanted to make sure I understood the legal structure that we're talking about. And then when it comes to, Senator Ratty, you mentioned that we're eliminating the informed consent. As a lawyer, I balk at that, not because it's not cumbersome, it's certainly that. But I would suggest we might want to talk to the legal eagles on this because informed consent or lack of informed consent could open the pharmacy then to some legal liability. I don't know the extent of that. This is not my area of expertise, but I just wanted to toss that out there. And that's all I had, Madam Chair. It looks like Dr. Slamowitz, though, wants to respond to that. So well, Dr. Slamowitz, that's a question to you.
And before she jumps in, I did neglect to introduce Michael Hillaby, who is also here representing the Board of Pharmacy. I apologize, Michael. Please go ahead, Beth.
Thank you. So I just wanted to jump in really quick and make sure that it's clear that we're not eliminating informed consent. That can still happen just within the agreement and, you know, dictated between the practitioners as to what both the provider of care is comfortable with, as well as what the pharmacist is comfortable with and what is done in terms of legalities. And then also want to be clear that these are voluntary. You know, I don't think you're going to see every Walgreens and every CVS and every Vaughn's, you know, jump into the arena. It obviously is going to be based on, you know, capacity and willingness and opportunity and whether or not it makes sense for that community. But I do know, especially in our rural settings, it is a huge opportunity for them to work with physicians that perhaps are, 100 miles or more or whatnot away. Many states, the way that they've put these in place with community pharmacies are not, complicated drug therapy types of managements. It's usually involves point of care testing, something that pharmacists are already allowed to do within this state. The problem or the roadblock is that pharmacists currently under NRS are allowed to take specimens, but they're not allowed to read or respond to a test unless it's under a collaborative practice agreement. And because that doesn't currently occur in a retail setting, simple point of care testing, such as Senator Ratty mentioned with a strep test, or even something like a rapid flu test, and then to be able to treat that person immediately is not something that can currently occur under current statute. So I just wanted to make those few clarifications.
No, and I appreciate that. That does clarify to me. And just so you're aware, the informed consent I was talking about was between the pharmacist and the patient. It's that interface that, the patient always needs to know that the pharmacist is not a doctor and is not necessarily trained to do all that a doctor would do. And if we were to curtail that informed consent, I think it might open up the pharmacist to legal liability. But again, not my area of expertise, just wanted to toss that out there. Thank you, Madam Chair.
Thank you for the question, Senator Pickard. And I will just say we are open to an amendment that leaves the informed consent piece in place. It's not the critical piece of this bill. I also did just want to follow up to just make clear, we're spending a lot of time and energy talking about the retail environment. And I think that that's important because for the rapid flu that gets you that flu antiviral that you need within 48 hours, it's ideal, right? But these also could be used in an HIV clinic where there's a specific pharmacist who is trained specifically to deal with that or a cancer location. And in that scope of, or in that collaborative agreement, there's going to be a significantly different list of things that that pharmacist can do in that agreement with that doctor and that specialty versus what you might see a Walgreens sign up for, which would be perhaps strep and flu. So that's why it's so important that the details end up in the collaborative agreement and not in NRS, where we're trying to micromanage that relationship between a pharmacist and a doctor and a patient, where we can make a patient's life significantly easier in a multitude of settings by trying to get it all in NRS. That agreement between the doctor and the physician is critically important because it does allow us to do some things now where, particularly in rural Nevada, folks are having to drive significant distances because of the limitations that we put in place.
Okay, thank you for that. Chair Spearman is back. I will turn the gavel over to her. The next person is Senator Hardy.
Thank you, Vice Chair.
Thank you, Madam Chair, if I may.
Yes, and if you can get a little closer to your microphone, Senator Hardy.
I've got a little thing that says somebody muted me, so apparently they didn't, so I'm okay. I gave Senator Ratty a list at first blush of my questions yesterday. So obviously what we're talking about is a pharmacist allowed to practice the art and science of medicine independently, albeit covered by a collaborative agreement with the physician, and the physician is nowhere near. And I'll use the example of the strep test. One of the reasons we treat strep throat is to prevent rheumatic fever. And so this pharmacist, as far as I know, doesn't have a stethoscope, isn't trained in murmurs, and so documenting what a person has before and after they're treated becomes an issue. It's easy to say, well, they can do a simple test and do a simple treatment, and that's good when it works, except when it goes south. So the ability to order lab tests, do studies, interpret the studies, follow up with appointments, do an examination. Then the obvious question for the physician is, who's got the liability? The physician obviously would have the deeper pocket, I would think, unless the pharmacist is working for CVS, and then CVS has deeper pockets than anybody else. How many pharmacists can one doctor have a collaborative agreement with? Is there one doctor in Clark County, for instance, that can say, I'm going to take all of the pharmacists in CVS or all of the pharmacists in
Senator
Walgreens?
Hardy, may I interrupt you there and take just those 2 questions and then we'll come back for more?
Yep.
Great. So, Mr. Porath, do you want to try to take either of those, or?
So I can speak to how things operate currently, which is obviously problematic because in the current state, each individual pharmacist and each individual physician have to be listed out in the agreement. And so I think that that's really been the barrier in the community pharmacy setting, is that we do have to have that individually listed out. From a liability perspective, Senator Hardy is absolutely correct. I mean, everything is being done ultimately under the authority of the practitioner. And so while, all pharmacists involved in collaborative practice work are encouraged to have individual liability coverage, in most cases with collaborative practice agreements, the physician is the deeper pocket, and that's where that's going to lie.
And so just to be clear on this point, we think that's a good thing. And let me say why I think it's a good thing. So there are other ways that you can get to similar outcomes. But if there's still liability in the equation for the physician and for the pharmacist, then the likelihood that folks are going to enter into collaborative practice agreements that aren't well backed up by scope of practice and research that these are going to be generally safe things that are being done, you're not likely to see folks enter into those collaborative agreements. So we do not want wholesale collaborative agreements that are going to open up significant risk for patients. We want thoughtful, conscientious practitioners, and practitioners both on the physician side and on the pharmacist side for making thoughtful decisions about how to get patients care.
Excuse me, Senator Reddy, Mr. Pratt, will you please introduce yourself every time you speak so our secretaries know who's talking?
Apologize, Chair.
Madam Chair, if I may.
Yes.
I did not hear the answer to my question as to a limit or how many. I mean, we talked doctor staff, physician assistants, and we limit how many physician assistants, and these are basically people who are not a physician assistant but are going to be in that role.
Right. Thank you, Senator Hardy, for the question. You're right, we missed that answer. So there is no limit in NRS because the limits could be very different depending on what is in that collaborative practice agreement. So again, going back to the flu example, you may have one physician for lots of pharmacists in a retail setting where we're comfortable with the ability to take a rapid flu test and then to do a prescription for. We may not have that same comfort level, clearly would not have that same comfort level if we're talking about a controlled substance in a cancer pain management clinic, where there's going to be a much likelier relationship, tighter relationship between a physician and a pharmacist who's working in that kind of a collaborative agreement. So those limits get defined in the practice agreement based on the agreement between the physician. The physician doesn't have to sign that agreement. Pharmacist doesn't have to sign that agreement. This is all voluntary. So those two professionals with their professional background make that decision within that agreement.
So if I may then, what is the motivation for the physician to take on liability for which the physician has no control of what happens day to day in a collaborative agreement. And I guess Adam would be the one to say, you know, is the pharmacist hired by the doctor? Is there a sharing of the fee? Is there an employment agreement? You know, what would motivate a physician to take on liability that the physician has little control over?
Let me just start, Senator Reddy, for the record, and then I'll turn it over to Mr. Porath. So again, I want to emphasize the collaborative practice agreements are already in place with no limits. So there's enough, the market is tested and there's enough motivation that these already exist. And this is just removing some barriers. So I just want to make sure that that point is clear. Mr. Porath, or Dr. Porath, excuse me.
Thank you. For the record, Adam Porath, Vice Chair Neal, Senator Hardy. To answer your question, in my experience, most of these arrangements have the pharmacists operating as employees of either a pharmacy or a healthcare facility. As far as any monetary relationship between the practitioner and the pharmacist, typically does not exist. The motivation from the practitioner perspective is severalfold, I think. Number one, they are increasing access to care for their patients. And so the pharmacist can see them in between the visits that they have. If they have in my practice, I deal with a lot of cardiovascular disease, diabetes, blood pressure, et cetera. And so when we have patients that are struggling with those disease states, the practitioners aren't necessarily able to see them as often as a pharmacist might be able to touch base with them, check their blood pressure, and adjust their medications. So it's an access thing. I think the evidence supports, especially with chronic disease states, that co-management between a pharmacist and a physician improves outcomes across the board. It's proven in blood pressure and cholesterol and diabetes, et cetera. And so that's the motivation for practitioners to get into these relationships, is because they think it's going to improve care.
Okay, get to my question.
In the interest of time, Senator Hardy, can you take the rest of them offline, please?
I'd be happy to. Thank you, Madam Chair.
Okay, thank you, sir. Vice Chair Neal, I think you're next.
Thank you, Senator Spearman. So I just have one question, and it's dealing with the retail pharmacy piece of this. So I understand where we're going and why we're going this way, but the clinical service that would then be offered by a pharmacist with a doctorate, I mean, what is going to be the compensation structure for those pharmacists? Because typically that clinical service is rolled into their salary. They are not allowed to use the MPI, which is their provider identifier number, or establish themselves outside of the retail pharmacy space. And this is additional work. So in the reality, you know, a pharmacist can deal with so many characters that come through: drug addicts, people who have other issues. And they become this frontline person, but they are not compensated for that activity, which this is an expansion of.
Thank you for the question, Senator Neal. I'm going to start with Dr. Porath to talk about the financial model that he works in, which is a little different than retail, and then ask Ms. McMiniman if she can talk about the retail environment.
Sure. For the record, Adam Porath again. Chair Spearman, through you, I guess, to Vice Chair Neal, to answer your question, currently most collaborative practice agreements, the financial arrangement is that the facility that the pharmacist is working with will collect the evaluation and management charges, and then the pharmacist is, as you said, an employee of that facility. And so there's no really financial incentive for the pharmacist to get involved in this work. When we talk about the transition to how this would work in a retail setting, there has to be a transition of the expectations of a community pharmacist to move away from producing a certain number of prescriptions an hour to this other value-based activity. And so there does need to be, otherwise what incentive would there be for Walgreens to have their pharmacists involved in this work? If they're not filling prescriptions and they're doing this other clinical activity, then they're not making money. And so in this scenario, the scenario that we're talking about with a community pharmacy setting, there is these point of care tests are a revenue generating activity. And so without direct remuneration for the clinical services that a pharmacist is providing, and which there is no mechanism in this bill for that to exist, that would be something that would have to be negotiated with payers, as far as what that would look like. And it's been an ongoing struggle in my practice, I can tell you, but there isn't that incentive. So the incentive would have to be through the employer.
Well, I'm glad you brought it up, and I'd love to talk offline if that's an opportunity, because at the end of the day, pharmacists earned their degree and their credentials, and they didn't go to medical school on purpose. And if they're going to engage in this practice, with more work and the quotas that exist within retail, right? Because there are true quotas that have to be met, and there are criteria and actual, it's like the work, their evaluations, which they are then judged on for failing to perform within this retail environment. And so I think that incentive matters. I think it matters one hell of a lot, because this is their time and this is their expertise that is they're being used, although for good reasons, they are not being compensated in that structure. So that's my really end of my comments on that.
Thank you, Senator Neal. Liz McMenamin, did you have an answer?
Actually, thank you, Senator Ratty and Madam Chair. Liz McMenamin, Retail Association in Nevada. And I just wanted to add to Senator Neal's, add a little something to what Adam Porth said. In other states, this practice has been ongoing. The change of the makeup in a community pharmacy is changing, and what we're going to see going forward in utilizing that pharmacist in the highest best good of their education level. So I think what I will do, Senator Neal, for you is I will talk to some of our nationals and find out how this works in other states, because I know that this has been implemented in many other states. We've had some roadblocks in Nevada in the past to expand the community pharmacy to be able to provide these type of services through things like utilizing our techs in the pharmacy and getting that pharmacist out there to do the practice that they've been educated to do, as opposed to being back behind the pharmacy and reaching those quotas that you talked about, Senator Neal. I get it. And I will work with you offline. We'll get the answers to that question and find out how that works as far as the compensation for the pharmacist who is working in those type of settings.
Yeah, and I will just say that I don't think we can get to the compensation structure until we have eliminated the barriers in NRS to allow for the model to work. So there are so many barriers in NRS now, you couldn't build a financial model that would make sense for any of the parties. And so until we remove some of the barriers in NRS to collaborative practice, which again, already exists in paper, and there are some collaborative practice agreements that are underway in our state, but to truly be able to use this group of professionals to the top of their education in a way that I think that they would find more fulfilling in their day job, whether that still ends up being a salaried position or something else. We need to remove the barriers to NRS to make the collaborative practice agreement work, is what I would add. And Senator Julia Ratty, for the record, my apologies, Chair.
Thank you, Senator Ratty. And with that, I don't see any other hands up. With that, let's go to the phones for comment. And we will have 15 minutes for support, 15 for opposition, 15 for neutral. Broadcast.
Thank you, Chair. To testify in support of SB 229, please press *9 now to take your place in the queue. Caller with the last 3 digits of 781, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good afternoon, Chair and members of the committee. Nick Vanderpool, N-I-C-K, V-A-N-D-E-R-P-O-E-L with Capital Partners, today representing the Reno Sparks Chamber of Commerce. Here today to support Senate Bill 229. Senate Bill 229, as outlined, expands access to health care to Nevadans, especially in rural Nevada. We know there is a doctor shortage in Nevada, so with this bill, it will fill a much-needed gap in services. During this pandemic, pharmacists played even more of an essential role, and this bill allows them to continue serving Nevadans in even more needed role. In conclusion, we appreciate Senator Ratty for bringing forth SB 229 and urge your support. Thank you, Chair and committee members.
Caller with the last 3 digits of 893, please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits of 893, we can see you're unmuted. Please begin your testimony.
Good morning. My name is Vasudha Gupta, V-A-S-U-D-H-A, last name G-U-P-T-A. I am an associate professor at Roseman University College of Pharmacy and a board-certified clinical pharmacist at a federally qualified health center in Henderson. I am representing Nevada Pharmacy Alliance, and we fully support Senate Bill 229. As part of my clinical responsibilities, I provide direct patient care to a medically complex, underserved population. I optimize the use of medications for chronic diseases to ensure efficacy while limiting adverse effects and misuse in collaboration with primary care providers. The providers that I work with will attest that I am a valuable part of the healthcare team helping to improve care through medication management. This is especially true for disease states that are mostly managed through complex groups of medications and require significant education, such as diabetes. No other healthcare providers receive 4 years of a doctorate education that's primarily focused on the management of diseases utilizing medications. I'm knowledgeable about the 30 different types of insulins that are available on the market, and oftentimes, more so than the primary care providers, I'm aware of which ones of those are most likely to be covered by the patient's insurance. However, most community health centers and primary care offices do not have a clinical pharmacist to provide these services. Most pharmacists are located in community pharmacies, as we've discussed, and the current restrictions in implementing the CPA in a pharmacy limit the provision of care and make it impossible for pharmacists to provide these services. For example, if a patient is experiencing low blood sugar, without a doubt, the community pharmacist has the knowledge to determine which of the 5 diabetes medications the patient is taking is most likely to cause low blood sugar. Rather than the patient stopping some or all of their diabetes medications on their own because of the scary side effects and waiting for an appointment with a primary care provider 3 months from now, the patient can have the discussion with the pharmacist when picking up their medications on at least a monthly basis and make modifications to avoid a gap in therapy. SB 229 allows for appropriate loosening of those restrictions so that unnecessary requirements don't hinder pharmacists from using their medication expertise to expand access to healthcare for Nevadans. I want to emphasize that pharmacists are still acting within their scope of practice and still in collaboration with practitioners, and those roles are clearly delineated within the CPA. Nevada is ranked 48th in the nation for primary care physician access. Allowing pharmacists to practice effectively within their scope of knowledge and abilities will increase access to care and ultimately reduce healthcare burden and costs. Thank you for the opportunity to speak.
Caller with the last 3 digits of 582, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Hi, Crystal Riccio, K-R-Y-S-T-A-L, last name R-I-C-C-I-O for the record. I'm a 22-year resident of Nevada, an associate professor of pharmacy practice with Roseman University, and one of the few primary care pharmacists in Nevada. Today, I'm speaking personally in support of Senate Bill 229, increasing access to care for Nevadans in rural, frontier, and even urban communities. Many of these residents live in a desert, both literally and figuratively, within a medical desert. Nevada has a disparate shortage in primary care physicians, and this bill is a step in the right direction to increase access to medical care. Medical providers and CMS have long promoted the concept of team-based care for years, with pharmacists as an essential part of an effective care team. Physicians are provided extensive education and training in physical assessment and diagnoses, while pharmacists receive years of education and training in providing medication therapy management. I've worked collaboratively within physician groups for over a decade to provide optimized care for our patients as a significant part of our care team, providing extensive education and chronic disease management within the scope of my practice. I am board certified as an ambulatory care pharmacist, and after thousands of years of practice, I'm also certified diabetes care and education specialist. Despite years of practice developing rapport and trust with my patients and physicians alike, barriers in our past and present legislation assuage my pursuit of a formal collaborative practice agreement in the state of Nevada. Unfortunately, practice without a CPA creates its own barriers, requiring physicians to be on site during all of my patient encounters and requiring me to interrupt a physician's own practice day to get approval for any medication changes I'm recommending. Specifically, this has caused me to cancel patient appointments due to physician illness, physician off-site meetings, or other last-minute physician schedule changes. Despite these barriers, we avoided pursuing a CPA due to the cumbersome process required for the initial approval, consistent amendments based on frequent guideline and medication changes, and annual renewal process through the Nevada Board of Pharmacy. This bill will open up an opportunity to streamline the process and allow the trust between a pharmacist and a practitioner collaboration to provide improved access to care for Nevadans. I strongly support SB 229 and thank you for your time and consideration.
Caller with the last three digits of 787. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Hello, everyone. My name is Amy Hale, A-M-Y-H-A-L-E. I'm a clinical pharmacist for Optum Care Cancer Care in Las Vegas, Nevada, and I would like to voice my support for SB 229. So I previously worked under a collaborative practice agreement, but we did let it lapse due to many difficulties we encountered, including delays of reapproval of the agreement if we wanted to adjust any language or any of our pharmacist provided services. I do have the full support of all the physicians with whom I work, and they did all sign the previous collaborative practice agreement. Patients with kidney problems see a nephrologist, patients who have cancer see an oncologist, so it does make sense that we as medication experts manage a patient's medication therapy after a provider has made a diagnosis. Our training is also similar to physicians, but it's focused on medications. We complete a significant number of clinical training hours in school, and many of us, especially those of us who work in specialty areas in hospitals and outpatient clinics, complete residencies and hold board certifications just like physicians do. Most physicians who trained with clinical pharmacists will also speak to how they used pharmacists to make patient care decisions, and they still consult pharmacists when they encounter difficult patient cases and recognize us as critical members of an interdisciplinary healthcare team. One issue we encountered after the dissolution of my collaborative practice agreement is an increased burden on providers. They had relied on me to make appropriate dosing adjustments per our protocols, adjust supportive care per peer-reviewed and evidence-based guidelines, interchange drug products per our internal formulary, and also to follow up on tests and labs that were needed for specific medications. So now they must be repeatedly interrupted throughout their day to implement these changes that they feel are well within the scope of practice of a trusted pharmacist, or they wouldn't have signed the original agreement. My days actually usually end with a number of providers in my office. We discuss the patients they saw during that day, and they ask for my opinion on how to proceed in their cancer therapies. In an assessment of the value of a clinical pharmacist in our clinic, I have a 97% acceptance rate for my recommendations to our physicians. I do hesitate to address this piece because I absolutely recognize the importance of it, but my physicians did actually question my need to request an informed consent from our patients. This required our providers to know which patient required closer attention from them because they couldn't rely on those pharmacist interventions to happen independently. They also stated that our nurse practitioners are not required to obtain an additional informed consent before those nurse practitioners see a physician's patients, nor are patients required to sign an informed consent to have pharmacists call a physician on a patient's behalf in the retail setting. So in summary, I feel that removing barriers to collaborative practice agreements allows for more comprehensive healthcare teams and actually greater communication between providers and pharmacists. It can reduce delays in care by having a pharmacist immediately resolve issues with a medication, and it can augment the patient-provider relationship by having more trained eyes evaluate a patient's therapy, resulting in better controlled healthcare costs. This has actually been shown in a number of studies. In my clinic alone, we showed a reduction of $20,000 in a single month by reducing unnecessary prescribing simply through pharmacist interventions, and it can result in improved outcomes.
Caller with
Thank
the
you,
last
caller. If
three.
you submit the rest of your comments in writing, written comments in writing to our committee, I'd appreciate it. Thank you.
Oh, thank you, Chair. Caller with the last three digits of 124, please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 124, please press *6 now to unmute yourself. Caller with the last three digits of 124, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Chair and members of the committee. For the record, Paul Moradkan, M-O-R-A-D-K-H-A-N with the Vegas Chamber. The Chamber is in support of SB 229 and appreciates the bill sponsor for bringing the bill forward today. I will be brief. As you've heard, this bill will be another tool in expanding healthcare access and conveniency for Nevadans. As we continue to work to address the doctor shortage throughout our state, this bill will help us in the short term for the benefit of patients. This bill will allow for greater efficiencies and utilization within the healthcare delivery system in our state. Thank you, Chair and members of the committee.
Caller with the last three digits of 005, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Hello, my name is Ken Kunke, K-E-N-K-U-N-K-E, and I am here today representing the Nevada Pharmacy Alliance. We are excited to expand our ability to be able to take care of patients, and I am here to show you our support for Senate Bill 229. Since the Pharmacy Collaborative Practice Bill passed, it has been difficult for pharmacists to be able to put it into action. In May of 2020, we sent out a survey to 14 pharmacists who are working inside clinics. All 14 of them responded to the survey, but only 5 of those individuals reported that they were currently working under a CPA. As we talked to them, it became clear that the current law is stopping them from entering into the agreements and being able to truly be part of the healthcare team. Currently, 48 states have collaborative practice laws. Some of those laws are very restrictive, like ours, but others are allowing pharmacists to truly use the skills that they learned in school to treat patients at the best of their ability. You may be wondering how providers and pharmacists enter into these agreements. In 2016, a resource called Advancing Team-Based Care Through Collaborative Practice Agreements was created. It is endorsed by many organizations, including the CDC, American Association of Nurse Practitioners, and the American Medical Association. I would encourage you to look into this document. Earlier, you heard some scary numbers of access to care for patients in our state, and you heard examples of how this bill would open up access. We have 2,470 licensed pharmacists that are ready to step up and help our patients. I am asking you to please show your support for Senate Bill 229. Thank you.
Thank you. Broadcast, we have one more speaker and then our time will be up and we will move to opposition.
Thank you, Chair. Caller with the last three digits of 456, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Yes, my name is Kaylin Bowman, K-A-Y-L-Y-N-N-B-O-W-M-A-N, and I'm here representing myself as a licensed pharmacist practicing in Nevada for 14 years. I have practiced in multiple settings, including community and hospital pharmacies and neighborhood medical clinics. Currently, I am the clinical pharmacist at Roseman Medical Group, working collaboratively with the providers as part of a team-based care model.
This collaboration was a result of 6 months of meetings, clinical service contract negotiations, and approval to work outside of a licensed pharmacy from the Nevada State Board of Pharmacy. I currently do not have a collaborative practice agreement in place. However, I plan to pursue this in the near future, and that is why this legislation is very important to me. Progressing to a collaborative practice agreement is the next step based on the trust built within the clinic setting between myself and other providers. The CPA agreement process requiring approval by state or legislative boards is a concern to me since it may result in increased approval time and burden of added paperwork. Allowing the pharmacists and providers to complete the CPA agreement will allow for timely implementation of expanded care for patient access and improved patient health and wellness. As a member of the healthcare team, I have increased patient awareness of medication adherence, further support behavior changes, and self-management of chronic disease and illness. Having the CPA will maximize my role as a pharmacist and utilize my skills to my fullest ability and training. There is more to being a pharmacist beyond the dispensing of medications. I have been an immunizing pharmacist since 2005. That was when I was still a pharmacy student intern. I provide drug information, I initiate naloxone therapy. I have been trained as a lifestyle coach for patients with diabetes, high blood pressure, high cholesterol, smoking cessation, nutrition and weight management, and now within the clinic, I provide medication therapy management services, chronic disease monitoring and education, all of which are within my scope of practice and per existing state protocol. So how will the CPA legislation make a difference? I will be able to collaborate more efficiently and effectively with the team care members, improve healthcare outcomes of our patients, and thus build healthier communities in Nevada. And that is why I'm asking you to show your support for Senate Bill 229. Thank you for your time.
Thank you, Broadcast. We'll now go to 15 minutes of opposition.
Thank you, Chair. To testify in opposition of SB 229, please press star 9 now to take your place in the queue. Again, to testify in opposition of SB 229, please press star 9 now to take your place in the queue. Chair, you have no callers in opposition at this time.
Thank you. Neutral?
To testify neutral on SB 229, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 327. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Chair, committee members. For the record, this is Joe Malay, last name M-A-L-A-Y, Deputy at the Division of Public and Behavioral Health. PPBH is neutral on SB 229 and believe this bill creates flexibility in these collaborative drug therapy management agreements. Pharmacists become part of the treatment team by working directly with patients to manage disease and can help reduce costs in medication management. Also, this bill allows for pharmacists to perform point-of-care testing, which may impact how the access for testing of COVID may expand. Thank you.
To testify neutral on SB 229, please press star 9 now to take your place in the queue. Chair, you have no more callers neutral at this time.
Okay, thank you. And let me just say, by way of explanation, some may wonder why we're doing a rather abbreviated form. We have to walk a fine line. We only have 120 days to get things done. And there are so many people that when they look at the calendar, they see the floor will be convening at 11 o'clock. Many of them base the rest of their schedule around that. And so we want to be acknowledged. We want to acknowledge their time and effort, but we also want to make sure that we acknowledge the time and effort of the presenter and the questions. So it's a very fine line, and I hope that I have walked that line judiciously today. Senator Ratty, you have any closing remarks?
I will be brief in my closing remarks. Thank you. So again, Senator Ratty, representing Senate District 13. First, thank you to yourself and the committee for the opportunity to present this bill. It has been a personal mission of mine since I've had the privilege to be elected to this seat to increase access to healthcare Honestly, we don't have many tools that we can use. And so when we do have a tool, we should use that. We have 2,470 pharmacists who are ready to step up and into their roles that they are already educated for, roles that they are already approved for their scope of practice, in collaboration with physicians across our state. And there are already collaborative practice agreement laws in place. We just have a few barriers we need to remove to actually make these effective. So again, thank you for your time, and I would appreciate your support on SB 229, and we will work on getting additional answers to any outstanding questions. Thank you so much.
Thank you, Senator Ratty. I will now close the hearing on Senate Bill 229. We'll open it up for public comment. Public comment.
To speak in public comment, please press *9 now to take your place in the queue. Chair, your line is open and working, and you have no one in public comment at this time.
Okay, thank you so much. And thank you, committee members and Vice Chair for taking over when I had to go to another bill. And as I said a few minutes ago, we're trying to walk a fine line between respecting the time of those who have arranged their schedules, their work schedules and lunch schedules around us convening at 11, and also want to recognize the time and effort that was put in by the presenter and acknowledge the questions from our committee members. We have 120 days every other year, and so whatever we don't get done this year, it will be a year and a half before we can come back and address it. And so that's why I try to make sure that we are we're recognizing the time, we're observing the time, and making sure we're making the very best of it. So with that, thank you so much, and we will adjourn, and we will be back here on Friday. Thank you, committee. We're adjourned.